So my dear friends, welcome to this session of Neet PG Elite Test Discussion. We conducted two tests for you guys, focusing on very important questions of the Neet PG paper. And let us start discussion. I'm Dr. Rajiv Dhawan, your ENT faculty with DocTutorials. The first question is about this device shown in the picture, and the question is asking all are true for this device except. Now, first of all, look at the device. This is bone anchored hearing aid. This is BAHA, bone anchored hearing aid. And what is not true about it? It has surgically implantable titanium fixture, correct. It transmits sound to cochlea directly through bone conduction on the principle of osseointegration, correct, absolutely correct. So basically, bone anchored hearing aid would be transmitting sound directly to cochlea via bone conduction using the principle of osseointegration. Number 3, it is indicated in a patient of external auditory canal atresia, absolutely correct. This is one of the prime indication. Number 4, it's not indicated in patient with chronic discharging ear, not indicated. This is a wrong statement. The answer to this question is D. In fact, chronic discharging ear is absolutely a very important indication of bone anchored hearing aid. This is bone anchored hearing aid when you put a screw on the skull bone over here, and then you attach the processor, the sound processor, onto the screw, which is this one. Okay. Now, bone anchored hearing aid has got 3 parts. It's a specialized surgery in which a titanium screw is fixed to skull bone, and then an external sound processor is attached to the screw through an attachment which is called abutment. The attachment is called abutment. A-B-U-T-M-E-N-T. Abutment. The attachment is called abutment. Okay. So once again, the number 1 is titanium screw. Number 2 is external sound processor. That processor is attached to a screw through an attachment called abutment. Now, what are the indication of BAHA? The most important indication is EAC atresia. The canal is atretic. How can you use a normal hearing aid? Number 2 is canal is wet, chronic discharging ear. My dear friends, please see, wet ear. Very important indication. If there's a pus in the ear, why would you put a hearing aid in the pus? The moisture will spoil the hearing aid in one day only. So better would be put a screw over here and attach the hearing aid onto that screw. This is a very important indication of this device. The third indication is anoxia. Look at the screen. Anoxia, absence of pinna. When there's no pinna, you cannot put a normal hearing aid. So 3 prime indication of bone anchored hearing aid are, let us revise. Number 1 is the EAC atresia, second is chronic discharging ear, and third is anoxia. What are the 2 indications? The fourth is EAC stenosis. The canal is very narrow, the hearing aid will not go. And number 5 is unilateral severe SNHL. On single side, there is severe sensory neural hearing loss that would be requiring bone anchored hearing aid. Okay, let's go further. Question number 2. A congenitally profound deaf child on radiological evaluation of cochlea and brain with MRI CT has been found to have Mondini's dysplasia of cochlea with the presence of normal 8th nerve. Cochlea is dysplastic, but 8th nerve is normal. Okay. Now, there is a famous question. Is cochlear dysplasia a contraindication of cochlear implant surgery? No. The cochlear implant surgery can be done in dysplastic cochlea. Look at the patient profile. The patient is having profound deafness. Okay. What is the main indication of cochlear implant surgery? Bilateral profound SNHL. Bilateral profound SNHL. Okay, fine. Now, for cochlear implant surgery, the cochlea can be dysplastic. That's not a problem. We can do the surgery still. Guys, normal cochlea has 2 3/4 turns. Okay, but the dysplastic cochlea, the Mondini's dysplasia of cochlea has 1.5 turn only. So, what is Mondini's dysplasia? 1.5 turn of cochlea. Is this a contraindication of this device? No. Mondini's dysplasia or any other dysplasia is not a contraindication of cochlear implant surgery. Now, what is the prerequisite of cochlear implant surgery? The answer is normal 8 nerve. So, this patient has got the indication of cochlear implant, which is the profound hearing loss. The patient has got a prerequisite of the cochlear implant also clarified is the normal 8 nerve. So, answer to this question is cochlear implant surgery. Cochlear implant. Now, this is your cochlea. Normal cochlea is 2, 3 by 4 turns. Okay. Now, this one is the external component of cochlear implant, which you every day wear, every night remove it. It has got 4 parts. Let's revise. What are 4 parts? Number 1 is microphone. Number 2 is the transmitter. Transmitter is a circular part which transmits current to the internal component. Number 3 is speech processor and number 4 is battery. Once again, what are the 4 parts of external component of the cochlear implant? Number 1 microphone, number 2 transmitter, which is circular part which transmit current to the internal component, and number 3 is speech processor and number 4 is battery. Regarding the internal component, this is called receiver, stimulator or electrode. Receiver, stimulator or electrode. This is surgically implanted in the scala tympani of cochlea. In which part of cochlea you put the cochlear implant electrode? Scala tympani of cochlea. Through which window? Through round window. 2 questions. The cochlear implant electrode is inserted into scala tympani of cochlea through round window. Okay. Now, please see, whenever you do cochlear implant surgery, you have put a beautiful electrode in the cochlea and cochlea is getting current. But the most important thing is, prerequisite of implant is normal 8 nerve. 8 nerve has to be normal. If 8 nerve is not normal, then please do not do cochlear implant surgery. Okay. Now, how do we put the implant? The most commonly used approach for cochlear implant surgery is transmastoid approach. Okay. Now, this is the cavity of cortical mastoidectomy. This is the cortical mastoidectomy cavity. This is the bigger, bowl is cortical mastoidectomy cavity, this one. Now, this is called posterior tympanotomy window. Posterior tympanotomy window. My dear friends, the most common approach for cochlear implant surgery is transmastoid approach, and you are seeing the picture of the transmastoid approach. First of all, you open the mastoid and that surgery step is called cortical mastoidectomy, and this bigger bowl is called mastoid cavity. This window is called posterior tympanotomy window. And what is the surgical landmark for posterior tympanotomy? The answer is facial recess. Facial recess is the surgical landmark for posterior tympanotomy. So, this window is called posterior tympanotomy. Where this window has been created, that area is called facial recess. Okay. Now, what about the brainstem? When you do the brainstem implant surgery, the most important indication of brainstem implant surgery is neurofibroma type 2. Neurofibroma type 2, if you remember, neurofibroma type 2 has got bilateral vestibular schwannoma. You can see in this MRI also, this is one tumor, other tumor. Neurofibroma type 2, NF2, 2 will remind you 2 tumors. NF2, neurofibroma type 2 is characterized by the presence of bilateral vestibular schwannoma. Means both 8 nerve are faulty. So, in that case, what you need to do? You need to do auditory brainstem implant surgery, because the prerequisite of cochlear implant surgery is normal 8 nerve, but in neurofibroma type 2, the 8 nerve is faulty, both sides. So, this patient cannot be benefited with the cochlear implant surgery. This patient has to be going for the auditory brainstem implant surgery. What is the other indication? The other indication is congenital aplasia of 8 nerve. Congenital aplasia of 8 nerve. The 8 nerve is not formed. Third one, cochlear aplasia. Aplasia. If cochlea is not formed, how can you do cochlear implant surgery? In dysplastic cochlea, you can do cochlear implant surgery. In cochlear aplasia, you go for the auditory brainstem implant surgery. Okay. Now, where do you put the brainstem implant? So, what is the location of auditory brainstem implant? Answer is lateral recess of fourth ventricle. Mind you, the cochlear implant surgery is, the implant is placed in scala tympani of cochlea. The brainstem implant surgery, the electrode is placed in the lateral recessive fourth ventricle, and the main indication of the brainstem implant is neurofibroma type 2. Other rare indications are congenital aplasia of the 8th nerve or congenital aplasia of the cochlea. Okay, now next one. Not a true match about the anatomical aspect of the ear. Corner septum is a remnant of petrosquamous suture is the correct statement. My dear friends, the most important step of mastoid surgery is finding the antrum. If you remember, antrum is the most constant and largest mastoid ear cell. So any mastoid surgery, the first step would be finding the antrum. What is the surgical landmark for antrum? The surgical landmark for antrum is this triangle. This triangle is called McEwan's triangle. McEwan's triangle or suprameatal triangle. This is the surgical landmark for finding the mastoid antrum. But in some people, even if you drill in this area, you're not able to find the antrum because they have got embryological error, and that error is called corner septum. Now, corner septum, 3 points to remember. Corner septum is found in few people. It's an anatomical variation. It's an embryological error. It's a remnant of which suture? It's a remnant of petrosquamous suture. Very famous question of embryology also. Corner septum is due to persistence of which suture? Petrosquamous suture. What is the surgical significance of corner septum? The answer is whenever corner septum is present, it makes the finding of antrum very difficult. Okay, so corner septum leads to difficulty in finding the antrum. Okay, now let us look at the other choices. Subiculum is a bony spicule which separates oval and round window. Correct. Processus cochleariformis indicate a basal turn of cochlea. Wrong. It's not processus cochleariformis. It's promontory. Promontory indicates the basal turn of cochlea. And pyramid on the posterior wall. We discussed many times in the class, in the app also, that pyramid on the posterior wall. How to remember? Pyramid is Egyptian pyramid. They belong to our history, past. Past on the backside of the posterior wall. So pyramid is on which wall? Posterior wall. Let us see the few important points of middle ear. Now, what is promontory? Promontory is the projection of basal turn of cochlea on the medial wall of middle ear. See over here. This is your middle ear and this is your basal turn of the cochlea. Now, this projection of basal turn of cochlea on the medial wall of middle ear is called promontory. Promontory. Now, what is pyramid? Now, pyramid is a projection on the posterior wall of middle ear. Please see over here. This is your pyramid. This is your pyramid. Now, pyramid is a projection on the posterior wall of middle ear. From pyramid, which muscle comes out? Stapedius. And it attaches to which ossicle? Stapes. So, pyramid, past side, back side, posterior side. Pyramid is a projection on the posterior wall of middle ear from which stapedius muscle comes out and attaches to stapes. And let us revise. Promontory is something else, beta. Promontory is a projection of basal turn of cochlea on the medial wall of middle ear. So, my dear friends, are you clear about these two terminologies? Promontory and pyramid? Promontory and pyramid. Are you clear about these terminologies? Okay. Now, let us see two more terminologies. Ponticulus and subiculum. These are two bony spicules. Ponticulus P, subiculum S. These are two bony spicules on the medial wall of middle ear. So, ponticulus is from promontory to pyramid. Ponticulus is a bony spicule from promontory to pyramid. So, how to remember? P. Ponticulus, promontory, pyramid. Subiculum, S for subiculum, S for separates. Subiculum separates oval window and round window. S for subiculum, S for separates. There are two bony spicule on the medial wall of middle ear. Ponticulus is from promontory to pyramid and subiculum separates oval window from round window. Now guys, very interesting thing is, between the ponticulus P and subiculum S, there is a hidden area called sinus tympani. Sinus tympani is a hidden area in the middle ear whose upper boundary is ponticulus and lower boundary is subiculum. Okay, fine. Sinus tympani is an important question. Now, it's a hidden area. Now, what are processus cochleariformis? Processus cochleariformis is again a landmark on the medial wall of the middle ear. This is a surgical landmark for the first genuofacial nerve. Once again, processus cochleariformis is a landmark on the medial wall of middle ear. It's a surgical landmark for the first genu of the facial nerve. Then the question is, what is the surgical landmark for the second genuofacial nerve? The answer is lateral semicircular canal bulge. Lateral semicircular canal bulge. Okay. So the first genu landmark is processus cochleariformis, and the second genuofacial nerve, the landmark is lateral semicircular canal bulge. Now, very famous question, visual question, beta. Now, this is your mastoid cavity in front of you, and EAC is external auditory canal. The question asked in the exam is, what is this surgical landmark? This star one. This surgical landmark is lateral SCC bulge. Lateral semicircular canal bulge. So, whenever they show you a bulge in the floor of the mastoid cavity, the answer is lateral semicircular canal bulge, and that's a surgical landmark for the second genu of the facial nerve. Okay, fine. Now, guys, look at this one, this picture. Now, this is the medial wall of middle ear. The floor of the picture is medial wall of middle ear. What is this yellow arrow indicating? This is pyramid. Pyramid. Pyramid is on the posterior wall. Guys, please see, may I draw? This is the posterior wall of the middle ear. The floor of the picture right now in front of you is the medial wall of middle ear. So, pyramid, may I remove it? Pyramid is a projection on the posterior wall of middle ear. Now, please see on the screen. This is, of course, stapedius muscle. If you remember, from pyramid, which muscle comes out? Stapedius. Then what is this ossicle? Stapes. Stapes. Okay. What is this ossicle? Incus. What is this joint? Incudostapedial joint. Okay. Then what is this window? This window is oval window. Oval window. Because oval window is the place where the foot plate of stapes is attached. So stapes is placed at which window? Oval window. Then what is this window? This is round window. Oval and round window. What is this projection on the medial wall of middle ear called? This is called promontory. Promontory. If this is promontory and you can see pyramid, then this must be ponticulus. If you remember, ponticulus is from promontory to pyramid. Okay. This is ponticulus. This ledge is called subiculum. Right above the oval window, there is a ledge called subiculum. You know, two bony spicule. Ponticulus, see on the screen. Ponticulus is from promontory to pyramid. Subiculum separates oval window and round window. Then this must be sinus tympani area. You remember, sinus tympani is a hidden area between the ponticulus and subiculum. And very famous question is, sinus tympani is the most common site of residual cholestoma after mastoid surgery. Sinus tympani is a hidden area between ponticulus and subiculum. And because it's a hidden area, it's the most common site of residual cholestoma after mastoid surgery. So this is a very famous, picture. Get scared of middle ear. It's a very fantastic structure to understand. And if you understand this picture, revise this one more time. Believe me, you will not be scared of this middle ear anatomy. Let's go further. One of the following is a feature of Meniere's disease. Meniere's disease has got diplecusis. Diplecusis. Meniere disease has got diplecusis. Patient hears same sound in two frequencies. Diplecusis is a feature of Meniere's disease. Meniere's. Okay. Hyperacusis is a feature of Bell's palsy. The sound appears louder, Bell's palsy. This is due to loss of which reflex? Stapedial reflex. Remember, stapedius muscle is supplied by facial nerve. In Bell's palsy, the facial nerve is gone. Stapedius muscle function is gone. So due to that loss of stapedial reflex, you feel hyperacusis. So hyperacusis is a feature of Bell's palsy. Now, paracusis Willisii is a feature of otosclerosis. Otosclerosis. Remember, in otosclerosis, patient hear better in noisy area, and this is called paracusis Willisii. Presbycusis is age-related SNH. Age-related sensory neural loss. This is 4 cusis of ear. Okay, once again, diplecusis feature of Meniere's, hyperacusis feature of Bell's palsy, paracusis Willisii is a feature of otosclerosis, and the presbycusis is age-related SNHF. What is this audiological investigation shown in the picture? Guys, this is otoacoustic emission, OAE. These are echoes of the cochlea produced by outer hair cells. MCQ, outer hair cell, O for O. Otoacoustic emission are echoes. When you give sound to the ear, some echoes come back from cochlea. Those echo are called otoacoustic emission, and these echo are produced by the outer hair cells of the cochlea. So it's a very interesting investigation. You give sound to the ear and some echoes come back to you. Those echo are called otoacoustic emission and they are produced by outer hair cells of the cochlea. Let's go further. Which of the following causes rapid otalgia through vagus nerve? Please see. Just please see. Ear is supplied by many nerves. Fifth nerve, trigeminal, through auriculotemporal nerve. Ninth nerve, it gives branch the middle ear called tympanic branch of glossopharyngeal nerve, also called Jacobson's nerve. Then 10th nerve, vagus nerve also gives one branch to the ear called auricular branch of vagus, also called as Arnold's nerve. So all these areas pain, 5th nerve, 9th nerve, 10th nerve, these area problems can radiate the pain from this area to the ear. So this area belong to 5th nerve, tonsil area belong to the 9th nerve, larynx, laryngopharynx area belong to 10th nerve. So which of the following cause rapid otalgia through vagus nerve? The answer is hypopharyngeal malignancy. Means pyriform sinus. Pyriform sinus, which is a part of laryngopharynx or hypopharynx, okay, and supraglottic cancer. Laryngeal supraglottic cancer, they both cause throat pain referred to ear via the 10th nerve, vagus nerve. If you remember, vagus has got two branches, RLN, SLN. This is supplied by vagus through two branches, recurrent nerve, superior nerve. Okay, and same vagus give branch to the middle ear, also to the ear called the auricular branch of vagus. This supplies the exonotory canal and little bit of pinna also. Okay, so the answer to this question is D. Tonsillectomy related pain goes to ear via glossopharyngeal nerve. Temporomandibular joint pain goes to ear via 5th nerve, trigeminal nerve. Eagle syndrome pain goes to the ear via the, again, 9th nerve. You know Eagle syndrome? Long styloid process pressing the 9th nerve, it lead to throat pain referred to ear. Okay, so please be very easy. Dental pain, temporomandibular joint pain goes to ear via 5th nerve. Tonsillectomy pain, styalgia, Eagle syndrome pain go to ear via 9th nerve. Larynx, laryngopharynx, supraglottic cancer, Parkinson's cancer, they give earache through 10th nerve. 10th nerve. Okay, the answer is D. D. Now, next one. One of the following is not a common feature of vestibular schwannoma, which is the other name of acoustic neuroma. This is a 8th nerve tumor, which is a brain tumor and mostly unilateral. Now, this is your acoustic neuroma, also called as vestibular schwannoma. And you can see very nicely, this is a cerebellopontine angle brain tumor. Now guys, please look at the question. This tumor is known to involve the trigeminal nerve. One of the earliest feature of this tumor is trigeminal nerve involvement and that lead to absent corneal reflex. That's a correct statement. Rollover phenomenon is positive. Yes, absolutely correct. What is rollover phenomenon? It means that the understanding capability of the person decreases when the other person raises the intensity of sound. Okay, the patient has got problem in understanding because it's a brain tumor, but if the other person start raising the intensity of his sound, this person will have even more problem in understanding the words. This is called rollover phenomenon. Okay, facial palsy is not a common feature. Why? I will tell you. Facial nerve has got two divisions, the sensory division and motor division. Facial nerve has got two divisions, sensory and motor. Sensory division is very thin, so commonly involved. And this sensory division involvement will lead to Hitzelberger sign. Hitzelberger sign. Now, what is Hitzelberger sign? Hitzelberger sign is loss of sensation in the posterior superior part of external canal. If you revise in your mind the nerve supply of external canal, okay, please see. Look at this sensory nerve supply of the external canal. the first nerve, the second nerve, and the third nerve. Look at the third nerve. The sensory division of facial nerve, it supplies the posterior superior part of EAC, and in this tumor, acoustic neuroma, the sensory division of facial nerve is involved. So there is loss of sensation in the posterior superior part of EAC, and this is called Hitzelberger sign. Because this area of the EAC is supplied by sensory division of facial nerve. But the motor division of facial nerve is very thick. So motor division is very rarely involved. Therefore, facial palsy is a rare feature. It's not a common feature. So what is the answer to this question is C. C. Common feature. Facial palsy is a rare feature. Okay, fine. Am I clear? Beta, fine. So Hitzelberger sign is loss of sensation in the posterior superior part of the EAC. Now the next one. The most common site of cholestoma in the middle ear is. Cholestomas mostly form in the upper part of the middle ear, which is called epitympanum or attic beta. But which part of epitympanum? The answer is Prusak space. Prusak space in epitympanum. I agree. The cholestomas mostly form in the upper part of middle ear called epitympanum or attic. But which part of epitympanum? Answer is Prusak space of epitympanum. So A is not the correct answer. More precise answer is Prusak space of the epitympanum. Now where is this space? Now please see PS. Can you see PS? Now Prusak space. Prusak space. This is space between pars flaccida and the neck of the malleus. Can you see over there? This is your pars flaccida, the upper part of tympanic membrane, and this is your neck of malleus. So guys, this area which I'm making yellow now, this is the Prusak space. So Prusak space is actually the space between the pars flaccida, the upper part of tympanic membrane, and the neck of malleus. So, and Prusak space is a part of epitympanum. So the most common site of cholestoma formation is Prusak space of epitympanum. Okay, fine. Prusak space. Next question, beta. One of the following is not a canal wall down procedure, beta. Not a canal wall down procedure. Are you getting my point? Not a canal wall down. Now please see. What is canal wall up and canal wall down? Very simple. After mastoid surgery, you have two options. Number one is the mastoid cavity is separate from the external canal. This is called canal wall up. What is canal wall? Canal wall is this wall, posterior wall of the EAC. Up means intact. In canal wall up, the posterior wall of the EAC is intact. So canal wall means posterior wall of the EAC, up means intact. Okay. Canal wall down. In canal wall down, you open the mastoid cavity into external auditory canal by removing the posterior wall of the EAC. This is called canal wall down. What is canal wall? Canal wall is posterior wall of the EAC. Down means removed. So what are canal wall up procedures and what are canal wall down procedures? Guys, please see. The classical example of canal wall up procedure is cortical mastodectomy, also called Schwartz operation. The other name of cortical mastectomy is Schwartz operation. The second example of canal wall up is combined approach tympanoplasty. Combined approach tympanoplasty, which is a common surgery done for limited cholestoma. Okay. This is also called intact canal wall mastectomy. Look at the name, intact canal wall. The question is saying intact canal wall mastectomy. Okay. So let us revise. What are the two examples of canal wall up surgeries? The classical one is cortical mastectomy, also called Schwartz operation. The second example, new surgery, combined approach tympanoplasty, also called intact canal wall mastectomy, which is nowadays being done for limited cholestoma. What are the example of canal wall down surgery? MRM, modified radical mastectomy. Number 2, radical mastectomy. And number 3, etechotomy. Once again, let's revise. What are the various example of canal wall down procedures? Modified radical mastectomy. Number 2, radical mastectomy. Number 3, etechotomy. Okay. Let's go back to the question and see. Now see, you answer yourself. Which of the following is not a canal wall down procedure? Means it's a canal wall up procedure. Of course, Schwartz operation, also called as cortical mastectomy. This is the canal wall up surgery. The remaining modified radical and etechotomy are example of canal wall down surgeries. Okay. Now, question number 10. A patient of Bell's palsy shows no improvement after 3 weeks of steroid therapy. Generally, 85% patients show very nice recovery after 3 weeks of steroid therapy. But now, the patient did not show any recovery after 3 weeks of steroid therapy. Now, what is the next level of management in such cases? The answer is electrophysiological nerve testing of facial nerve. Electrophysiological nerve testing of facial nerve, like electroneuronography. Now, why you're doing this electroneuronography? You want to see how many fibers of the facial nerve are showing the evidence of degeneration. Now, there can be two reports of electroneuronography. It can be significant degeneration or insignificant. Okay, significant means 90% or above, and insignificant means below 90%. Okay, now he says that no significant facial nerve degeneration means less than 90% fibers show the degeneration evidence over there. If that's the report, no need to worry. Just continue with steroids and repeat assessment. Do not worry. It means that the nerve has not started to die actually. There's no significant evidence of degeneration, means you are still safe. Then the answer will be continue steroid, but yes, intermittently keep repeating the same testing over there. But if it is significant, more than 90%, then the answer would have been facial nerve decompression. Okay, surgery. So let's revise. If the electrophysiological nerve testing shows insignificant facial nerve degeneration evidence, then no need to really worry. Continue steroid and repeat the testing. But if it shows significant degeneration, means more than 90% fibers, then you do immediate surgical decompression of the facial nerve, because the edema might kill the nerve permanently. Okay. The answer to this question is B. If the same question is asked like the significant degeneration, then the answer would have been C, facial nerve decompression. Now, which is not from the medial wall of middle ear. We just did that. Processus cochleariformis, yes. Secondary tympanic membrane is equal to round window membrane, yes. That's the medial wall. We discussed that wall also. Subiculum, remember subiculum is a bony spicule on the medial wall of middle ear. It is separating the oval window and round window. But facial recess is on the posterior wall of middle ear. Facial recess on the posterior wall of middle ear. Okay, facial recess is on the posterior wall of middle ear. Please see, this is your facial nerve. This is the vertical segment or the mastoid segment of facial nerve. From this branch comes cauda tympani. Cauda tympani. Okay, then imagine this area, star area, is facial recess area. Very famous question of the paper. All are boundaries of facial recess except the first boundary of facial recess is vertical segment or mastoid segment of the facial nerve. The second boundary is called tympani. The third boundary is the short process of incus or fossa incutis, because short process incus is lying in fossa incutis. Let's revise once again. What are three boundaries of facial recess? Neat PG question. Number one, vertical segment or mastoid segment of facial nerve. Number two, choroid tympani nerve. Number three, short process incus or fossa incutis. Okay. Now, what is the surgical significance of facial recess? Remember, this window is called posterior tympanotomy window, and the surgical landmark for posterior tympanotomy is facial recess. Okay, so this window is called posterior tympanotomy, where this window has been created, and that area is called facial recess. Once again, facial recess is on the posterior wall of middle ear. That's why you're doing posterior tympanotomy. Posterior tympanotomy, you're opening the middle ear from behind. So, which is the surgical landmark for creating a posterior tympanotomy window? The answer is facial recess. Okay, fine. Now, all are applicable to globus jugulare, very famous tumor, very vascular tumor, which is more common in females. Don't forget that. The tumor is more common in females, yes. And this tumor is growing below the floor of the middle ear around jugular bulb, called glomus jugulare. Now, please do remember, this is a type of paraganglionoma, just like pheochromocytoma. Glomus jugulare, pathology wise, it's a tumor belonging to the group called paraganglionoma. The other example of paraganglionoma is, which you know, is pheochromocytoma. Pheochromocytoma. Okay. So please do remember, 10% of glomus jugulae also secrete catecholamines, just like the pheochromocytomas. Therefore, very advanced question. In glomus jugulae also, you must get 24-hour urinary VMA level done. What is VMA? Vanillyl mandelic acid. The same test is done for pheochromocytoma. So please do remember, glomus jugulae is an ENT cousin of pheochromocytoma. So pathology wise, it resembles that. That's why you see cell balls of Zalbalan on histopathology. Correct statement. Now, please see, the tumor is growing below the floor of the middle ear. Okay, let me show you. Here, everybody see on the screen, tumor is growing over here, below the floor of middle ear. Now, it's a benign but locally invasive tumor. It grows into middle ear like this. Now, this is called rising sun sign. Okay, fine. Now, please see, the tumor will erode the tympanic membrane and grow into the external auditory canal as a red bleeding mass. Okay, can you see the two things over there? This one, now this is called the rising sun sign. Okay, fine, rising sun, because the tumor is growing into middle ear from below upward, and therefore rising sun sign. Now, tumor erodes the tympanic membrane and grows into EAC as a red bleeding mass. Now, if you do pneumatic otoscopy or Siegeleization, you know, Siegeleization means what? Putting air pressure on tympanic membrane. If you put air pressure, pneumatic otoscopy or Siegeleization, please see the red tumor will turn pale yellow. So, tumor blanches on Siegeleization or pneumatic otoscopy. This is called brown sign. Brown sign. Tumor is red in color and the tumor turns pale yellow when the Siegeleization is done. What is Siegeleization? Putting air pressure on tympanic membrane, also called pneumatic otoscopy. So, tumor blanching on Siegeleization is called brown sign. Brown sign. Now, important thing is, one more. It's a skull-based jugular foramen tumor. It's glomus jugulae. Where is the jugular bulb? At the jugular foramen. It's a skull-based jugular foramen tumor. Guys, this is your jugular foramen. The immediate neighbor of jugular foramen is carotid canal. Okay, carotid canal. Now, this is the bony septum separating the jugular foramen from carotid canal. Both of these are landmarks on the skull base area, and glomus jugulae is a skull-based jugular foramen tumor. As I told you, this is a locally invasive tumor. This is a locally invasive tumor. So, tumor which belongs to jugular foramen area, it will erode the bony septum between the jugular foramen and the carotid canal, and thus it will enter the carotid canal. Now, this sign is called the Phelps sign. This is called Phelps sign. What is Phelps sign? Phelps sign is erosion of bony septum between carotid canal and jugular foramen. Phelps sign is a radiological sign. It is the erosion of bony septum between the jugular foramen and carotid canal. That's how the tumor belongs to jugular foramen, but it enters the carotid canal, and via carotid canal it goes to brain also. Okay, fine. Now, let's see the question once again. Now, what is not true about this tumor? Please see, the answer is the B is correct, D is correct. Erosion of carotico-jugular spine is what? The Phelps sign. That's correct. It's a radiological sign. What is the treatment? The treatment is not bleomycin. Though it's a vascular thing, we don't inject bleomycin in this beta. The treatment is surgery. My dear friend, treatment is surgery. My dear Neet PG friends, make sure that you are doing the best of the hard work in the remaining days beta. Okay? Please see, you have got a lot of time to do the at least 2 revisions of the content if you finished one reading by now. Whatever stage you are in, don't compare your stage with somebody else's stage. Everybody has got a different journey to make. So, whichever stage you are, can you do your level best? Please write in the comment chat box also. Can you write it to yourself, note to yourself that wherever I am, as compared to other people, I may be actually having a lot of less preparation. But can I do my level best in the remaining days before Neet PG? Please write in the chat box your commitment to yourself, what you want to do in the remaining days. And may God bless your hard work. And please, please, please make sure that you don't leave any stone unturned. You don't leave any sacrifice which you could have made right now, because this is the most crucial phase of a doctor's life. Whether it happens or not, only God decides. But 80% of the game is in our hands, and that game is hard work. Let us do a lot of hard work. Let us do all sacrifices possible, and let us do smart hard work, study the high yield things, do the previous year questions, and do a very enthusiastic preparation for the examination. And the answer to this question is 12A. Okay. Now, next one, very famous topic. All are true about BPPV except. Yes, BPPV, if you remember, benign paroxysmal positional vertigo. Now, please see, this is your saccule, this is your utricle. The saccule and utricle contain what? What is this green thing? Macula. And macula is covered by gelatinous layer. And that gelatinous layer has got calcium carbonate crystals, which are called otolith or otoconia. Otolith or otoconia. By chance, if otolith enter the canal, the disease is called BPPV, benign paroxysmal positional vertigo. Mostly they enter which canal? Posterior semicircular canal. BPPV is the most common cause of peripheral vertigo, means ear-related vertigo. BPPV is the most common cause of peripheral vertigo. Please do remember, BPPV is more common in females. Now, what is the chief complaint of BPPV? Vertigo for few seconds, my dear friend, for few seconds, not for hours or minutes or days. Vertigo for few seconds on changing head position. Doctor, the moment I change position, I feel dizzy for few seconds, then I'm all right. Is there any hearing loss in this patient? No. There's no hearing loss in this patient. Any tinnitus? No. So only symptom is vertigo with nausea, vomiting, but no hearing loss, no tinnitus, and vertigo is also for few seconds only. Okay. Now, let us look at this question. All are true for BPPV except the vertigo sensation persists for 2 to 3 hours. Wrong. A is the answer. Otoconia mostly migrate to posterior canal. Correct. There is no hearing loss in this condition. Correct. And BPPV is the most common cause of peripheral vertigo. Correct. Okay, fine. Let's go further. Identify the instrument given in the picture. This instrument, look at the olive-shaped tip of the instrument. This is Pulitzer bag. Now, Pulitzer bag, my dear friends, Pulitzer bag is identified with the help of olive-shaped tip. This is Pulitzer bag. Can you see the olive-shaped tip? This tip, this one, this tip. This tip is kept in the nostril over there, and the test is called Eustachian tube Pulitzerization. This is a Eustachian tube function test. You are putting air in the nose through the help of Pulitzer bag, and you're trying to see the movement of tympanic membrane. When somebody deflates this cuff, do the tympanic membrane move or not? That is what we look for. So, Pulitzerization, which is done with the help of Pulitzer bag, is a Eustachian tube function test. Don't confuse this instrument with the Siegel speculum. Now, Siegel speculum is very different. This has got a magnifying glass. There's no glass in Pulitzer bag. Pulitzer bag has olive-shaped tip, but Siegel speculum has got a magnifying glass. Okay, so don't confuse these two instruments over there. Next one. Identify the prosthesis. Very easy question. This is grommet. Grommet. Okay, any white ring-like thing in tympanic membrane is grommet, and grommet is also called middle ear ventilation tube. Grommet, and grommet is mainly used in the treatment of glue ear. Glue ear, also called as otitis media with effusion. So G for glue, G for grommet, and grommet is placed in the antero-inferior part of tympanic membrane. Okay, so before you put the grommet, you always do myringotomy. Myringotomy in glue ear is done in antero-inferior quadrant. After you do the myringotomy, you suck the glue out and you put a grommet over there, and this is what the look of the grommet is. Okay, guys, fine. Now, guys, please see another prosthesis, PORP and TORP equal ORP, ossicular replacement prosthesis. They are made of titanium or Teflon, and they are of two types, partial and total, called PORP and TORP. PORP is used in which situation? M minus I minus S plus situation, means the disease, the CSOM has eroded the malleus, eroded the incus, but stapes is still there. When stapes is still there, when ossicles is still there, I need partial replacement. It's called PORP. So PORP is used in M minus I minus S plus situation. But TORP is used in M minus I minus stapes head minus situation. Please understand. Malleus is eroded, incus is eroded, and stapes head is also eroded. Nothing is left over there. Then you need total replacement. Very simple concept is, if stapes is still intact, you will use PORP, partial replacement. But if stapes is also gone, then you need, of course, total replacement device. Okay, fine. Microvic, new question possible. Microvic, this is microvic. Microvics, please see, this microvic, they are used for transtympanic injection of drugs. Please remember, microvics are used for transtympanic injection of the drugs. Okay, fine. Next question, beta. Very, very possible question. Superior canal division syndrome X. All are true except beta. Please see, this is your superior canal over here, and there is a opening in that canal. Beta. If you remember, bache, there are two windows we have. Oval window, round window. Now, unfortunately, the third window is created. Through this third window, what is happening? The sound energy is leaking. Beta. Okay? So, actually, cochlea is absolutely normal. So, there cannot be sensory neural hearing loss. Beta. This patient would not have sensory neural hearing loss because the cochlea is absolutely working normally. Why this patient has got hearing loss? Because the sound is not getting conducted properly. The sound is leaking through this dehiscence. Beta. So, that is why the patient will be having conductive hearing loss. Beta. The audiometry in this case will show conductive hearing loss. Very famous question. Now the leak, why there is a hearing loss? Beta? This is due to leakage of sound energy from this dehiscence. This is called third window phenomenon. Why this patient has got conductive hearing loss? Because of leakage of sound energy from this dehiscence, and this is called third window phenomenon. Third window phenomenon. Okay. This patient also gets vertigo on hearing loud sound. This is called Tullio's phenomenon. Tullio's phenomenon. Vertigo on hearing loud sound is called Tullio's phenomenon. This patient also get vertigo on blowing of nose. Doctor, when I clear my nose forcibly, I get vertigo also. What are the investigation would you keep in mind for this? HRCT and VAMP. Vestibular evoked myogenic potential. Two things you do to diagnose it: HRCT of the temporal bone and the vestibular evoked myogenic potential. Let us look at the question again. Please see. Which is not true about this? Third window phenomenon? Yes. SNHL? Wrong. It's not SNHL. Conductive hearing loss. The answer is B. Tullio phenomenon? Yes. VAMP is a useful investigation. Yes. VAMP is a useful investigation. For this? Absolutely yes. It's not SNHL. It's conductive hearing loss. Very, very, very important topic for the upcoming paper. Now, 5-year-old patient present with the history of hearing loss on examination is found to have pearly white mass behind tympanic membrane. Pearly white mass behind intact tympanic membrane. What is pearly white mass? It is cholestoma. Intact tympanic membrane indicate that cholestoma formed before birth actually. What is cholestoma? Skin in the middle ear. If TM is intact, it means skin has not gone from outside. It is there since birth. This type of cholestoma is called congenital cholestoma. Pearly white mass behind intact tympanic membrane. This is the visual question. Can you see over here? Pearly white mass behind intact tympanic membrane. This is called congenital cholestoma. Okay, congenital cholestoma. And the criteria used to diagnose a cholestoma to be congenital is called Levenson's criteria. Levenson's criteria is used to diagnose the congenital cholestoma. The main point is pearly white mass behind intact TM. That the key word is intact TM. Pearly white mass is cholestoma. Behind intact TM proves it, it's congenital cholestoma. And the criteria is called Levenson's criteria. What type of tympanogram is shown in the picture? Flat tympanogram, my dear friend. Flat tympanogram is type B curve. Type B. You remember flat? Normally it's like this. Normally type A. Type A is like this. Type A is the flat tympanogram. Okay. Type A is the team corrected over here. The type A is the normal tympanogram. Type B is the flat tympanogram. It is seen in two conditions, mainly glue ear. And number 2, perforated tympanic membrane. Type B tympanogram is seen in two situations. Number 1, glue ear, and number 2 is perforated tympanic membrane. Okay, fine. Don't forget, guys, AS tympanogram. S for sclerosis, otosclerosis. very low compliance curve beta. AD is ossicular dislocation. D1 is dislocation, ossicular dislocation. So S will remind you sclerosis, otosclerosis. AD, ossicular dislocation. Okay. AS is low compliance curve. AD is high compliance curve. B is flat curve. No movement. No movement. Glue ear. Glue ear is the main thing. Okay. Don't forget, glue ear is also called otitis media with effusion, also called serous otitis media. They are all same thing. Okay. Chalo. Now, next question. A patient of right unsafe CSOM has presented with a history of diplopia, double vision, and pain behind the right eye. Wow. It's a very, very possible question in the paper also. What is the further investigation? First of all, what is this entity? This entity is called petrositis, also called Grady-Negro syndrome. Grady-Negro syndrome, very famous question. Basically, look at the screen. This is the petrous apex area. At the petrous apex, we have got two nerves, fifth nerve and sixth nerve. If by chance abscess form in this area, infection of the petrous apex will lead to petrositis, also called as the Grady-Negro syndrome. So, if you see on the CT scan or MRI, you will see a white lesion over there. Okay. To diagnose this entity, you need a CT scan. Okay. So, the clinical suspicion is Grady-Negro syndrome, and the three features of Grady-Negro syndrome are, if you remember, the mnemonic we discussed in the class also, G, E, R, D. G for Grady-Negro syndrome, E for ear discharge, R for retroorbital pain due to fifth nerve involvement, and D for diplopia due to sixth nerve involvement. Once again, it is a suspected case of petrositis, which is also called Grady-Negro syndrome. It has got three features: E for ear discharge, R for retroorbital pain due to fifth nerve involvement, and D for diplopia due to sixth nerve involvement. Because we know at the petrous apex, we have got two nerves, fifth and sixth. To diagnose this entity, you need a CT scan for sure. That's what the question is. Look at the question again. He says, what is the further ideal investigation in this patient? Of course, HRCT temporal bone. B. HRCT temporal bone is the answer. Okay. Now, question number 20. Mohan, 22-year-old male, gives history of right-sided ear discharge, foul-smelling blood stain. My dear friend, foul-smelling blood stain ear discharge is a feature of unsafe CSOM, also called as aticoantral CSOM. One and the same thing. Unsafe CSOM is also called as aticoantral CSOM. For last 6 years, he also has hearing loss for last 2 years, but for last 3 days, he has developed fever, chills and headache, pallor and edema over the mastoid region. Now, headache always indicates intracranial complication. Whenever you see in a patient of unsafe CSOM or CSOM any headache, think about some brain problem. Okay. Now, this pitting edema over mastoid, the edema word pitting edema over mastoid is called Grissinger sign. Grissinger sign. This is a feature of the lateral sinus thrombosis, also called as sigmoid sinus thrombosis. Okay, please see over here. Right behind the ear, please see over there, beta. This is your ear over here. Ear. Right behind the ear, this sinus is called sigmoid sinus or lateral sinus. This sinus is called sigmoid sinus or lateral sinus. Unfortunately, in this sinus, there is a thrombus formation there. This is due to ear infection, the thrombus formed in the sigmoid sinus, and the entity is called sigmoid sinus thrombosis, also called lateral sinus thrombosis. The patient will develop pitting edema on the mastoid. This is called Grissinger sign. And number 2, headache is a very important, part of the intracranial complications of the CSOM. Remember, anytime you get a headache in a question of CSOM, think of intracranial problem. The answer to this question is the aticoantral CSOM with sigmoid sinus or lateral sinus thrombosis, and don't forget the word Grissinger sign. It is pitting edema on the mastoid. It's a feature of this entity. And don't forget headache concept also. Okay. Next one. 21. 50-year-old male patient presenting with the hearing loss, complaint on the left side. Audiometry is given in the picture. What is the diagnosis? I told you in the app also, in the class also, that in audiometry we see two lines beta. Air conduction, bone conduction beta. If both lines are above 25, it's normal. Okay. If you see, this is bone conduction and air conduction. BC is normal. Any line above 25 is normal. Any line below 25 is poor. BC is normal, AC is poor, and this gap is called AB gap. Now, AB gap means conductive hearing loss. Remember, very core point to remember, whenever you see AB gap, it's conductive hearing loss. When you see gap between two lines, AB gap is conductive hearing loss, and the minimum AB gap to be significant is at least 15 decibel. How much gap should be there? Minimum to be significant to call it conductive hearing loss should be 15 decibel or above. Okay. Now, SNHL. If both ACBC poor, if both ACBC are poor, it is SNHL. Because when cochlea is not working properly, you go through air conduction or you go through bone conduction, both will be poor actually. So, both ACBC poor is SNHL, AB gap is conductive hearing loss, and both line above 25 is a normal one. Now, look at this one. Now, both ACBC are below 25. Okay, below. So, this is SNHL, A. Sensory neural hearing loss. Both lines are below 25. It's sensory neural hearing loss. Now, I put a complete, video audiogram made easy on the same channel. Audiogram made easy. We put on the same channel. Is a complete video on audio. If you want to understand audiogram, there's a video on the same channel called audiogram made easy. Okay. Now, false regarding Bell's palsy. My dear friends, in Bell's palsy, which is the lower motor neuron facial palsy, generally on one side, the forehead muscles are also paralyzed. To remember, forehead muscles are not paralyzed in upper motor neuron lesion of the facial nerve. But Bell's palsy is a lower motor neuron lesion of the facial nerve. So, forehead muscles are also paralyzed. Okay, fine. Now, please see. First, false regarding A. A is the answer. Are also, but not, they're also paralyzed. Hyperacusis is a feature of Bell's palsy. We're done already, due to loss of stapedial reflex. Oral steroids are a drug of choice for 3 weeks, yes, and there are 85% chance of recovery. Absolutely correct. Fine. One more point to remember. Angle of mouth is deviated to normal side, and there is loss of which fold? Nasolabial fold. So, forehead muscle are also paralyzed. Angle of mouth is deviated to normal side, and loss of which fold? Nasolabial fold. Okay. 23. Tuning fork. Patient has complained of right side hearing loss. My dear friend, right side hearing loss, right is the poor ear. Right is the poor ear. Ear with the hearing loss is the poor ear. Left is the better ear. Okay, fine. Tuning fork tests show Rene is negative on right side. Tuning fork tests show Rene is negative on right side. Guys, Rene negative is conductive hearing loss. Okay, left is normal here, beta. So Rene is positive on that side. Guys, look at me, beta. If Rene is actually genuinely negative, Rene negative, look, Rene negative is a feature of conductive hearing loss. If Rene is genuinely negative in this patient, then Weber should be pointing to poor ear, means right ear. I repeat, Rene is negative in this case. If Rene has been genuinely negative in this case, then Weber would have been heard in the poor ear, which is the right ear. Okay. Now look at screen. He says Weber test is lateralized towards the left ear. Left is the better ear. Better ear. This says SNHL. Guys, Rene negative indicates conductive hearing loss. Please see. Rene negative. Please everybody see. The question says that Rene is negative. Rene is negative is conductive hearing loss. Weber is heard in the left ear, which is better ear, is saying SNHL. Can you make any sense out of this? No, it's actually nonsense. We discussed in the class also, app also, that whenever you are not able to make any sense of this, then it's a question of false negative Rene. False negative Rene, beta. False negative Rene is a feature of unilateral severe SNHL. The keyword is severe. Unilateral severe SNHL, beta. Okay. So guys, my dear friend, please read again. Rene is negative, but it is false negative. If Rene would have been genuinely negative, then Weber would have been heard in the right ear only, which is a poor ear. But the Weber is heard in the left ear, which is better ear. So, I cannot make any sense of this. He has given additional finding also that ABC test is normal on the left side, but decreased on the right side. ABC decreased is also a feature of SNHL. Beta. The answer is right severe SNHL. B. This is a question of false negative Rene, which is particularly seen in unilateral severe SNHL. Okay, so this is very, whenever you get confused in the paper, Rene is negative, but Weber is heard in the better ear, then what answer shall I make? Then it is a false negative Rene question. You have to crack the question very nicely, and please look for severe SNHL in the choice, and that's the correct choice. Okay, now 24. What is cupula in the inner ear? Please see over there. Cupula. Guys, please see, every canal has got sensory end organ called crista. Crista. Crista is this one. Crista lies in the ampulla of the canal. Ampulla is the dilated end of the canal, and crista is covered by gelatinous layer, and that gelatinous layer is called cupula. Cupula. Are you getting my point, beta? Ampulla is the house of crista, cupula is the cover of crista. Ampulla is the house of crista and cupula is the cover of crista, beta. So once again, ampulla is the dilated end of the semicircular canal. Crista is the sensory end organ of the semicircular canal which lies in the ampulla of the canal. Crista is covered by a gelatinous layer which is called cupula. Cupula. The answer of this question is the gelatinous layer around the crista, beta. Okay, D. Fine. Chalo. Next one. 25. All are true about temporal bone fractures except. Guys, look at screen. Beta. Temporal bone fractures can be of two types. Beta. Guys, please see. Either the fracture can be going like this, longitudinal, or it can be cutting the bone through and through, transverse. Beta. Guys, longitudinal are 80% of fracture. Beta. Transverse are 20%. Beta. 20%. Transverse are more dangerous. More dangerous. They are less dangerous. Okay. Longitudinal fracture damage middle ear. Transverse fracture damage inner ear. Therefore, longitudinal fracture lead to conductive hearing loss. The transverse fracture lead to SNHL. SNHL. Okay. One important difference is ear bleeding or CSF are more common in longitudinal fracture. How to remember? L for longitudinal, L for leaking. Leaking. If blood is leaking from the ear or CSF is leaking from the ear, think of longitudinal fracture. How to remember? L for leaking, L for longitudinal. So EAC bleeding, CSF are more common in longitudinal fracture. And one more point, beta. Facial nerve, beta. Please understand, the facial nerve passes through the ear, beta. Please see, the facial nerve will be going like this. Here, the facial nerve will be cut, beta. So guys, please see, in the longitudinal fracture, even if the facial nerve palsy is seen, which is less common, it will be delayed in onset. Why? Because there will be edema around the nerve, beta. Okay? So longitudinal fracture, the chances of facial nerve palsy are less common, and it is delayed onset facial palsy which needs steroids as a treatment of choice. But look at a transverse fracture. The facial nerve has been cut. So chances of facial nerve palsy are more in transverse fracture, and the facial palsy in transverse fracture is immediate in onset, and the reason is the facial nerve has been transected by the fracture, so the treatment will be immediate surgery of the patient. Okay, fine. Now, let us see it out there, which is not true about it. Transverse fracture are more commonly associated with facial palsy, correct. I told you, transverse fracture, the chance of facial palsy is more common and it is immediate. Beta. And immediate onset would need immediate surgery because facial nerve has been transected by transverse fracture. Beta. Ear bleeding is a suggestive of longitudinal fracture. Yes, I told you, ear bleeding or CSF are more common in longitudinal fracture. How to remember? Leaking, longitudinal. L for leaking, L for longitudinal. Beta. CSF is more common in transverse fracture. Wrong. CSF is more common in longitudinal fracture. C is the answer. Beta. I told you, ear bleeding, CSF are more common in longitudinal fracture. Beta. And the last one is important. Longitudinal fracture damage the middle ear more. Okay, therefore they called CHL. That's correct statement. So C is the answer. Beta. C is the wrong statement. The CSF is more common in longitudinal fracture. C is the answer. Okay. Now, what is the name of this middle ear prosthesis? I told you in the app, in the class also, anything like a question mark will be stapes piston prosthesis. Stapedial piston prosthesis, anything like a question mark, they are made of Teflon or titanium. They are used in the surgical treatment of otosclerosis. Stapes piston prosthesis is used in the surgical management of otosclerosis. In otosclerosis, the stapes is fixed. So in the surgery, when we take this device, look like question mark, the name of surgery is stapedectomy or stapedectomy. First you do the tympanotomy, you open the middle ear. First you do tympanotomy, you open the middle ear by lifting the tympanic membrane. Then you replace, look at screen, then you replace what? Then you replace the fixed stapes with stapes piston prosthesis. The name of disease is otosclerosis. The name of surgery is stapedectomy or stapedectomy, and the prosthesis is called the stapes piston prosthesis. In this surgery, we replace the fixed stapes with artificial stapes piston prosthesis. Okay? All are true about embryology of the ear development except cochlea and pinna development completes by 20th week is absolutely correct. Mastoid tip is absent at birth? Yes. Mastoid tip develop at 2 years of age? Correct. Middle ear ossicles attain adult size by 6 years of age? Wrong. D's answer. Guys, 3 structure are of adult size at birth only. Middle ear, ossicles, cochlea. Middle ear, ossicles, cochlea are of adult size at birth only, beta. Middle ear, ossicle, cochlea are of adult size at birth only. Okay, fine. The answer is D. D is the wrong statement. They are already of adult size at birth. 28. What is the name of this investigation? Very famous question, beta. This is called VAMP. Vestibular evoked myogenic potential. Look at me, beta. Your vertical balance, this vertical linear balance is under control of saccule. Saccule is continuously giving input to the neck muscle, beta. It's vertical balance like this. Okay. If you irritate the saccule, there will be some activity in the sternocleidomastoid muscle also. Look at the name. Vestibular evoked myogenic potential. Okay. What is vestibule, beta? Saccule. Okay. What is myogenic, beta? Sternocleidomastoid muscle. Can you see, beta, this muscle? Sternocleidomastoid muscle. In this test, we stimulate the saccule with loud sound and we record the electrical activity of sternocleidomastoid muscle. Vestibular evoked myogenic potential. Myogenic potential. In this test, we stimulate the saccule with loud sound and we record the electrical activity in sternocleidomastoid muscle. Okay. Now, VAMP is a test of number 1, saccule. Number 2, the nerve supply of the saccule. Number 2 is the inferior vestibular division of the 8th nerve. Very famous question. VAMP is a test of number 1, saccule, of course. Number 2, the inferior vestibular division of 8th nerve, which is the nerve supply of the saccule. Okay, once again, vestibular evoked myogenic potential. We stimulate the saccule with loud sound and we record the electrical activity in sternocleidomastoid muscle. Hence, it is a test of saccule and inferior vestibular division of the 8th nerve. Patient of head injury suffered hearing loss. You know, head injury, there can be a lot of, ossicle problem, tympanic membrane problem. This patient has got normal tympanic membrane with AD tympanogram. Guys, AD, I told you, it is seen in ossicular dislocation. Guys, ossicular dislocation due to trauma can have 2 situations, beta. With normal tympanic membrane, like this question, or with perforation, beta. There may be perforation also. As we discussed, that with normal tympanic membrane, hearing loss is more, 54 decibel conductive hearing loss. With perforation, the hearing loss is less, in fact, 38 decibel conductive hearing loss. Why? At least through the perforation, some sound energy is able to directly enter the middle ear. Okay, fine. The answer to this question is 54 decibel. Okay, but with perforation, it would have been 38 beta. Perforation 38 beta. But this question is normal tympanic membrane, so hearing loss is more. So ossicle dislocation can have 2 situations. Either it is with the normal tympanic membrane, like this question, or with perforated tympanic membrane. Surprisingly, with the normal tympanic membrane, hearing loss is more, 54. But with perforation, you get advantage. Why? Because through the hole, through air conduction, some sound energy is able to directly enter into the middle ear. Okay, that's why hearing loss is 38 decibel conductive hearing loss. And the last question of the ear. A child is born with deformed pinna. What is the name of deformity? This is bat ear, beta. What is bat ear? Please see, normal pinna has two curvatures, beta. The one curvature is called helix, the outer C. The inner is called anti-helix, beta. Helix and anti-helix. Every pinna has two curvatures. Look at mine. Outer curvature is called helix. The inner is called anti-helix. So helix is the capital C and anti-helix is the small c, beta. But if anti-helix is absent, it is called bat ear. Can you see beautiful bat, beta? Bat has got helix and no anti-helix. It's called bat ear. It is suiting her. She's looking so, like presentable. But our children will look like horrible. Like, you remember? Like, aliens. Amir Khan, remember? Like, ear will open like antenna like that. Beta. Please see. This is the typical look of the bat ear. Beta. There is helix, yes. There is no anti-helix. So, bat ear means absence of anti-helix. Beta. Okay. This reverse of the bat ear, beta, called Wildermuth ear, beta. Look at me, beta. Helix, the fold. Helix means this is fold, beta. Can you see the outer edge of pinna is folded? If this helical fold gets unfolded like this, this is called the Wildermuth ear. Wildermuth ear is absence of the helical fold. So please see, bat ear is absence of anti-helix. Wildermuth ear is the absence of helical fold or helix, beta. Okay. Third one is Mozart ear, beta. Mozart ear is the fusion of helix and anti-helix, beta. Mozart ear is fusion of helix and anti-helix. So 3 ear, beta. Bat ear, absence of anti-helix. Wildermuth ear, absence of helix. And fusion of helix and anti-helix is called Mozart ear. These children would need the plastic reconstruction of pinna, which is called otoplasty. Otoplasty. Now, what is the ideal age of otoplasty? Is 6 years or above. Why? Because by 6 years, pinna attains almost adult size. So, otoplasty, the plastic reconstruction of pinna for all these deformities is done at 6 years or later, because by that time, pinna gains maximum size. Okay. So, these are 30 questions of the year. Okay. So, my dear friends, after discussing the questions around the ear, let us go to the part 2, in which we discuss the questions of the larynx, nose and pharynx. The first question is of larynx. A 20-year-old male patient has got high-pitched voice. A male with high-pitched voice is puberphonia. You know, puberphonia, normal pitch of voice in male is low pitch. But a male having high-pitched voice, a disease called puberphonia. The laryngoscopy is normal. The clinician advises him speech therapy, in which he is asked to phonate while pulling the thyroid cartilage downward and pressing it backward. What is the name of this maneuver? The answer is Gutsman maneuver. So while you push the thyroid cartilage backward, you're pushing the vocal cord backward, they get loose. They get loose, and the loose cord will produce the low pitch sound, and we desire low pitch sound in males. So a male should have a low pitch voice, but a male having high pitch voice like a female is a disease called puberphonia. The primary treatment is speech therapy in the form of Gutsman maneuver. You do this exercise for 3 to 6 months, and definitely you need psychotherapy for the patient also, because these people definitely have issues around their confidence. Self-confidence is very poor. They're very inhibited, introvert, very shy kind of guys over there. So psychotherapy. Now problem is, if this fails, after 6 months also, no improvement in the sound, voice is there, then you do a surgery, and the surgery is called type 3 thyroplasty. The surgery is called type 3 thyroplasty. Thyroplasty. Okay. Now, what is type 3 thyroplasty? It is surgical shortening or loosening of vocal cord. The correct word is loosening. Okay. Look at my hand, beta. You press it backward surgically, anteroposteriorly like this. It will become loose. A loose cord will produce low pitch sound. So this surgery is called type 3 thyroplasty, which is technically the surgical loosening, also wrongly called surgical shortening of the vocal cord, because you are not cutting it short, you are making it loose. But yes, when you look at from above, the loose cord will look shorter. That's why. Okay, fine. Next one. All of following cannot be seen on laryngoscopy except. All of the following cannot be seen on. Cannot be seen means which can be seen. So never get confused in such question. Such question, all except, all cannot be seen except means what can be seen. The answer to this question is interarytenoid area is equal to posterior commissure. Posterior commissure. Okay, interarytenoid. Arytenoid is the back side of the vocal cord. So you can see the interarytenoid area or the posterior commissure. My dear friends, this is indirect laryngoscopy mirror. It's a straight mirror. Straight mirror. You warm the mirror before using so that there is no fogging of the mirror. After warming, you check it on the back of your hand and then you pull the patient tongue like this and you see the mirror image of the larynx. That's why called indirect laryngoscopy. Now the question is, the structures not visible on indirect laryngoscopy are: number one, anterior commissure of vocal cord. Look at my hand. This is anterior commissure of vocal cord. It's covered by epiglottis. Now, where is the mirror? Mirror on the roof right now. Mirror is there. We're on the roof right now. Please see, this is epiglottis. You can see the upper surface of epiglottis, but you cannot see the laryngeal surface or under surface of epiglottis. Okay. Number two, laryngeal surface of epiglottis or under surface. Number three, under surface of vocal cord. And below the vocal cord, whatever part of subglottis is there, you cannot see that also. Ventricle and saccule, you know, hidden areas. What is ventricle? Space between false cord and true cord. It's a hidden area. And from ventricle, we get a balloon out and that is called saccule. This is saccule. This is ventricle. Ventricle is space between false cord and true cord. Okay. And saccule is out pouching from ventricle. Try to recall your notes. Ventricle and saccule are hidden areas. And lastly, apex of piriform sinus. On the side of supraglottis, there is piriform sinus. You can't see the apex which is downward of the piriform sinus. Okay. So these are the structures not seen, but you can see the posterior commissure. Posterior commissure is the interarytenoid area. So the answer to this question is B. Okay, structure all cannot be seen except. So which can be seen means, can be seen is interarytenoid area or posterior commissure. Now, the next question. A patient of T3 N0 M0 carcinoma larynx has undergone total laryngectomy. He has permanent tracheostomy following this surgery. Now, after total laryngectomy, there is a permanent hole in the neck called permanent tracheostomy. He is using this device for vocal rehabilitation. What is the name of the device? This is, of course, electrolarynx, also called artificial larynx. Electrolarynx or artificial larynx is the name of device. Okay. Now, what kind of device is this? Now, this is actually a battery-operated handheld external vibrator. This is an external device. It is battery-operated handheld external vibrator. You charge it and whenever you want to speak, you touch in this area. This is a vibrating surface and that makes the oral mucosa vibrate, and any mucosa when it vibrates can produce sound. Okay. It's a wonderful device. The better option than this is a surgical option and that is called TEP device. Tracheoesophageal puncture device. What is TEP full form? Tracheoesophageal puncture device. The example is Blomsinger. Blomsinger. Prosthesis. Number 2, Pange. Provokes. Okay. All these are different example of TEP device. Now, what is the basic, functioning mechanism of TEP device? Look at screen. There is a unidirectional valve here. This is a unidirectional valve here, which is surgically placed between trachea and esophagus. It's a unidirectional valve. It allows the air to go from trachea to esophagus, which comes upward, and that air is used to phonate. Okay. So, tracheoesophageal puncture device is a surgical option. It's an internal device, which is a unidirectional valve-like device, which is surgically placed between trachea and esophagus. Okay. The example is Blomsinger, Pange and Provokes. Now, this is the visual question of the Neet PG paper. Please see, this is what? Anybody? This is the permanent tracheostomy hole. This is permanent tracheostomy hole. This is opening here. And this is what? This is the TEP device. If they ever show you on the posterior wall of trachea, a plastic nipple-like thing, this is TEP device, already asked question. My dear friend, already asked question. Am I clear? Beta fine. So once again, what is this bigger hole? This bigger hole is the hole of the permanent tracheostomy in the neck. What is this wall? This is the posterior wall of trachea. And what is this device? This is tracheoesophageal puncture device. Let's go further. 52-year-old female patient underwent thyroidectomy and the surgery had a complication. Both SLN got damaged. If you remember our notes, thyroid gland at the lower pole, we have got the RLN RLN. At the upper pole, we have got SLN. During thyroid surgery, in this patient, SLN got damaged. Now, what are the post-operative symptoms? Very easy question. Please see clinical, applied anatomy. Superior laryngeal nerve has got two branches, internal branch and external branch. The internal branch is sensory supply to supraglottis. It gives sensory supply to supraglottis. This is also called as internal laryngeal nerve. This time INACT question. Which nerve does not allow the aspiration to happen at the level of supraglottis? The answer was internal laryngeal nerve. It is the sensory supply of the supraglottis. Have you imagined, guys, when you are eating rice or something, one small rice particle enter your larynx. Larynx, gets so irritated. Sensation is so nice over there. You start violently coughing because nerve of cough is vagus nerve. SLN, RLN are branches of vagus nerve. So a rice particle enter your larynx, you get violent cough till the time you eject it out. So this actually internal laryngeal nerve is sensory supply to the supraglottis and this prevents aspiration. So this patient will be having chief complaint of aspiration. Aspiration. Okay. Now external branch supplies cricothyroid. And cricothyroid, if you remember, its main tensor. And tensor give us quality of voice. Tensor give us quality of voice. So the chief complaint will be poor quality of voice. Cricothyroid is the main tensor. And I hope you remember this famous statement, all muscles of larynx are supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by external branch of superior laryngeal nerve. So cricothyroid is the main tensor and that got damaged. That's why poor quality of voice. Now examination. The examination in this case of vocal cord will show bowed down vocal cord. Bowed down vocal cords. Look at me. When tensor are gone, the vocal cord become lax. This loose, lax vocal cord is called bowed down vocal cord. So the chief complaint will be aspiration and poor quality of voice. Let us see the answer. The answer to this question is A. Poor quality of voice and aspiration. A is the answer. Okay, fine. Now, next one. 3-month-old child is having persistent dyspnea and stridor since birth. Whenever anything says since birth, think of congenital anomalies over there. Okay, fine. The cry of the baby is normal. When they say cry of the baby is normal, it means vocal cords are normal. Means this anomaly would not be of the vocal cords. Now, on CT scan of the neck, the subglottic diameter has been found to be 2.5 mm. Guys, look at the screen. What is subglottis? Cricoid is a ring-like cartilage. Cricoid is a ring-like cartilage. It's a complete ring. Okay. And the space in that is called subglottis. This diameter of the cricoid ring is called subglottic diameter. Look at me. If cricoid is a ring, the empty space in that ring is called subglottis and this diameter of the ring is called subglottic diameter. If it is less than 3 millimeter in preterm baby or less than 4 millimeter in full term baby, it is called congenital subglottic stenosis. Congenital subglottic stenosis. Okay, fine. If less than 3 millimeter in preterm baby, is called congenital subglottic stenosis or less than 4 millimeter in full term baby. Now, for this we have got a Robin-Cotton or Cotton-Meyer classification. Cotton-Meyer grading. Cotton-Meyer grading of stenosis is important for the upcoming examination. Grade 1, 2, 3 and 4. Grade 1 is 0 to 50% obstruction. Grade 2 is 51 to 70%. Grade 3 is 71 to 99% and grade 4 is no lumen. No lumen. Look at screen. This is your cricoid ring. Normal one. Normal one. Okay. Now, please see, there is 50% obstruction. Grade 1. Okay. Now, then there is, you can say, the 51 to 70%. Then 71 to 99%. And lastly, grade 4 is no lumen, beta. No lumen. Are you getting my point, beta? Grading on CT scan. How we do it? On CT scan, beta. Treatment of grade 1 is conservative. Grade 1 is sufficient to survive, 50% airway is normal. Grade 2 and 3. Grade 2 is laser dilatation treatment. Laser dilatation treatment. You use the laser to break the fibrotic bands, followed by local application of mitomycin C. Followed by local application of mitomycin C, very famous question. It is actually a drug which is anti-cancer, but it has got anti-fibroblastic properties. Okay? It doesn't allow the restenosis. Now, grade 3, grade 4. You need a proper surgery called laryngotracheal reconstruction, in which what we do, you open up the cricoid cartilage like this and you put a rib cartilage graft over there. What is this? Rib cartilage graft. But because this graft needs some support for first few days, you put a tube for few days, and that tube is called Montgomery's tracheal T-tube. It's like this. Montgomery's tracheal T-tube. Okay, fine. Montgomery's tracheal T-tube. Now, let's revise. Grade 1 is 0 to 50% blockage, doesn't need any treatment. Grade 2 is 51 to 70% blockage, it needs laser dilatation surgery followed by application of mitomycin C. Grade 3, grade 4 are very severe problems. It needs proper surgery called laryngotracheal reconstruction, in which we put a rib cartilage graft to increase the diameter of the cricoid ring, followed by placement of Montgomery's tracheal T-tube for few days to support the graft. Okay, a little high level question, but expected in the exam. Okay, chalo. Next question. All are true about tracheostomy except the usual side of tracheostomy is second and third tracheal ring, correct? And this is called mid tracheostomy. Mid tracheostomy, correct. High tracheostomy is done at first and second ring, and this is done for cancer larynx. What is the indication of high tracheostomy? Cancer larynx. Normal side of tracheostomy is the second and third tracheal ring. It's called mid tracheostomy. High tracheostomy is first and second tracheal ring. It is done for cancer larynx. Number 2. In children, a circular ring of anterior tracheal wall is removed. Wrong. The answer is B. This is not a good right statement, beta. Now, why? Please see, in adult, trachea is hard. Hard, beta. Look, feel your trachea. It's hard, like a bamboo. So, you remove a circular ring of the anterior tracheal wall and then you put the tracheostomy tube. But in children, the trachea is very soft. So, you need not remove the ring of the cartilage of the trachea. You just give a vertical cut like that. Okay, like that. Look at me. Your trachea, my trachea is like a bamboo. A child trachea is like a rubber tube. On the rubber tube, a cycle rubber tube, you know. Even if you give a small cut, it will automatically open, beta. So, in children, you need not remove any circular part of the anterior tracheal wall. In adults, we need to remove a circular ring of the anterior tracheal wall to put the tube. But in children, we must avoid it because children trachea is already very weak. The answer is B. That's the answer. Decannulation is difficult in children. What is decannulation? Look at me. Every tracheostomy is temporary in nature except after total laryngectomy. Guys, after total laryngectomy in a patient of cancer larynx, patient has got permanent lifelong tracheostomy. Otherwise, tracheostomy is a temporary procedure. Decannulation is the final goodbye to tracheostomy. Decannulation means the final removal of tracheostomy tube once its purpose is over. For the cause for which you did the tracheostomy, that has been cured, treated properly. Now you can safely remove the tracheostomy tube. That process is called decannulation. It is the final removal of tracheostomy tube once its purpose is over. It's called decannulation. It is difficult process in children because children get dependent on tracheostomy. This is a correct statement. Decannulation is difficult in children. Therefore, in children, we never remove the tube in one go. 8 number remove one go. No. In adult, like we have got 8 number tube, we remove it, we seal it, finish. No, but in children, we downsize the tube. Downsize. What do you mean downsize? You have put the 6 number tube. You want to remove the tube? Don't remove it immediately. First, you put the 5 number tube, 4 number tube, 3 number tube, then half block it. Half block it. Okay. Then you finally remove it. Okay. Because children dependent on tracheostomy, they need to be phased out of that. Okay. So you downsize the tube. An elective tracheostomy is done with horizontal incision. Correct. Please see. Skin incision tracheostomy. In emergency tracheostomy, we give vertical skin incision. In emergency, we give vertical skin incision on the neck. Okay, but in elective tracheostomy, we give horizontal skin incision. Elective horizontal. Why so? The reason is, the emergency tracheostomy, you don't have time. The vertical skin incision will make the surgery quick, but scar is bad. But in emergency, when patient is dying, you don't care about the scar, beta. If your patient is having difficulty breathing and you think about scar, and I'm sure you'll have patient antim sanskar. You don't want patient antim sanskar. Rather than that, you can have a bad scar. That's not a problem. So in emergency, you are having lack of time. Vertical incision on the skin in this case will give you advantage, because vertical incision makes the surgery quick, but scar is bad. In elective tracheostomy, like this one, you have got a lot of time. Elective means patient is already intubated, on ventilator, no hurries, no worries, nothing, no problem, no need to panic over there. You give proper horizontal incision. The surgery in this case will take more time, but scar is better. Now you have the time, so no problem. So elective tracheostomy, horizontal skin incision. Emergency tracheostomy, vertical skin incision. Stroboscopy of larynx. What is stroboscopy first of all? Stroboscopy is normal endoscopy of the larynx using flashing light. Flashing light. Okay. Why you use flashing light? So that vocal cord movements appear in slow motion. The physics says that whenever you subject a moving object to a flashing light, it is visible in the slow motion actually. So normal endoscopy versus stroboscopy, rest everything is same. The only difference is light source. So the stroboscopy definition is the endoscopic examination of vocal cord done with the help of flashing light so that vocal cord movements appear in slow motion. This also shows sound wave formation on the vocal cord, the mucosal sound wave. Whenever vocal cord vibrate, they produce sound. You can see those vibration of the vocal cord in a very effective manner. Now, he's asking how this kind of investigation helps to differentiate benign from malignant lesions. Look at me. Both vocal cord, when they vibrate, the sound wave, the mucosal wave, is actually very periodic, very regular, very symmetrical. Imagine there is a lesion on vocal cord, there is a mass on one of the vocal cord. You have a doubt, is it cancer or no? You do stroboscopy. If because of this mass or lesion on a growth on the vocal cord, the mucosal wave of the vocal cord becomes irregular, then it is most likely malignant. I repeat, stroboscopy also shows you mucosal sound wave of the vocal cord. This waveform should be regular and periodic actually. If any mass lesion or growth on the vocal cord makes this mucosal wave irregular, then it means that this lesion or growth is most likely malignant, means I should take a biopsy tomorrow only. Okay? So the answer to this question is identification of preservation of normal mucosal wave of the vocal cord. If the mucosal wave is normal in architecture, it is regular, periodic, then this lesion, this growth over here is not cancer, it is benign. But if this growth or lesion makes this mucosal wave of vocal cord irregular, it's most likely malignant. Okay? So stroboscopy, the difference is flashing light. Flashing light makes the vocal cord in slow motion, and this shows sound wave formation of vocal cord. And it should be regular. If anything makes it irregular, it's most likely malignant lesion. Next one. Infant after birth is noticed to have stridor and a hoarse cry. The main thing is hoarse cry. Hoarse cry. All are possible diagnosis except. Now please see laryngeal web, hoarse cry. Okay, when a vocal cord involvement, okay, laryngeal paralysis, hoarse cry. Congenital laryngeal cyst, hoarse cry. But laryngomalacia, cry is normal. Try to recall your class or app lectures, cry is normal, beta. Cry is normal. In these three conditions, there is hoarse cry. Hoarse cry. Okay, fine, good. So answer is D, laryngomalacia. Because laryngomalacia, patient got stridor. Stridor is there. Okay, which type of stridor? Inspirate. Laryngomalacia has got inspiratory stridor. Remember? Inspiratory stridor. The stridor increases on crying, it decreases in prone position, and the shape of epiglottis is omega-shaped epiglottis. What is the treatment of laryngomalacia? Conservative treatment. Just reassure the parents it is self-limiting disease. Treatment of laryngomalacia is conservative treatment. Reassure the parents it is self-limiting disease. Kashima operation is done for, very important question, bilateral abductor pulse. Means vocal cord closed. Vocal cord closed. Look at screen. Bilateral abductor palsy. What is Kashima operation? This is, everybody, this is membranous part of vocal cord. This is cartilaginous part of vocal cord. If you cut the membranous part away from the cartilaginous part using CO2 laser, then this is called Kashima operation. Basically, you are trying to make the space for air to go in the body. Look at me. Membranous part is attached on the cartilaginous part. Okay. If you cut the membranous part at the end of the, the length of the membranous part, the membranous part like a curtain will fall backward. Okay. So what is Kashima operation? It is separation of membranous and cartilaginous part of vocal cord using CO2 laser. What is the aim of this surgery? Bilateral abductor palsy means both vocal cord are closed. You want to create some space for air to breathe for the patient. When you make a cut like this with CO2 laser, the membranous part will automatically fall backwards and that will open up the space for the air to enter to the lungs. This is called Kashima operation. Okay, fine. Otherwise, the treatment of choice of Kashima, the team corrected. Otherwise, the treatment of choice for bilateral abductor palsy is type 2 thoroplasty. Otherwise, try to recall the treatment of choice of bilateral abductor palsy is type 2 thoroplasty. It is lateralization of vocal cord. Lateralization of vocal cord. The treatment of choice is type 2 thoroplasty or lateralization of vocal cord. Kashima operation is other treatment of the same condition. Okay, fine. So, bilateral abductor palsy, both cord are closed permanently. The treatment of choice is vocal cord lateralization, also called type 2 thoroplasty. The other treatment, there are many. One of them is Kashima operation. It is separation of membranous and cartilaginous part of vocal cord using carbon dioxide laser. In a patient of acute epiglottitis, all the following are part of management except intubation is the first treatment. Airway. Epiglottitis is a serious airway pediatric emergency. The first treatment is intubation, then steroids to decrease edema, antibiotic to prevent infection because this is bacterial infection. Most common bacteria is Streptococcus pneumoniae. Second common is Haemophilus influenzae B. Okay, but repeat laryngoscopy should be avoided. Answer is D over here. Repeat laryngoscopy should be avoided because it will increase edema. Do not do repeated laryngoscopy because that will increase the edema. Okay, fine. So A, B, C are done, but D is not done. Not true about a recurrent respiratory papillomatosis of larynx, also called a juvenile papilloma of larynx. Okay, it's also called juvenile papilloma of larynx, also called a recurrent respiratory papillomatosis. It is caused by HPV 6 and 11. Okay, fine. And there are a lot of viral warts over there. There are a lot of viral warts over there. They are on the vocal cords, but they can also spread to trachea and bronchi. That's why it's called recurrent respiratory papillomatosis, or not only laryngeal papillomatosis. Now we call it, new name is recurrent respiratory papillomatosis. We use carbon dioxide laser to remove them. But problem is recurrence is very common. Recurrence is very common. And to decrease recurrence, we inject intralesional cidofovir. Intralesional cidofovir. So we burn these papilloma with the laser, but still recurrence is very common. Therefore, the intralesional cidofovir is helpful. Now look at the answer. Not true about the intralesional cidofovir can be used. Yes, this is for recurrence. B. B is wrong. Only involves supraglottic glottis? No. It can go to trachea bronchi. I told you. It is, the new name is recurrent respiratory papillomatosis. It means it's not purely laryngeal problem. It can extend to trachea and bronchi also. Okay, fine. So B is the answer. CO2 laser is helpful. Yes. HPV 611 is the causative organism. And my dear friends, please note down one more extra point to remember about this is a pre-malignant disease. Why? Pre-malignant disease. This is caused by HPV 611, and you know HPV is oncogenic virus. Okay. So human papilloma virus, the 611 causing juvenile papillomavirus can also lead to malignancy of larynx in the future. So this is a pre-malignant disease. Guys, don't forget intralesional cidofovir. This can be a standalone single liner question also. Which drug is used to prevent recurrence of juvenile papilloma? Answer is intralesional cidofovir. Gold standard test for LPR. You know, have you heard of GERD? The acid comes up in the throat is called LPR. LPR. Laryngopharyngeal reflux. Look at me. Acid come over here, GR. Acid come over here is LPR. When does it acid come on the laryngopharynx? When you lie down. Lie down. For this we do 24-hour double probe pH monitoring. Why 24-hour? Why? Because mostly acid comes in the throat at night. Why double probe? One probe at esophagus, lower end, one probe in the pharynx. Okay, fine. One probe here, one probe here. If this probe pH also falls, it's LPR. So 24-hour double probe pH monitoring is a diagnostic test for laryngopharyngeal reflux, LPR. Okay, fine. That's a 24-hour test. One probe is here, and the other probe is here. So basically, at the lower end of esophagus, at the upper end of esophagus actually. Okay, fine. The radiological presence of which sinus appears last in human life? The sequence of appearance of sinuses is MESF. The first sinus to appear in humans is maxillary. The last to appear is frontal. Sphenoid appears at 4 years of age and frontal at 6 years of age. That's a thing to remember. The sequence of appearance sinuses is MESF. The sphenoid appear at 4 years and the frontal appear at 6 years. 6 years on X-ray. How to remember the frontal 6 years? Look at me. One student told me very easy way. You know, frontal F. F is the sixth alphabet. F is sixth alphabet. A, B, C, D, E, F. F frontal, sixth alphabet, 6 years. 6 years. Okay. The answer is D, frontal sinus. So which sinus appears last in human life is frontal. The answer is this one. This is 6 years. All are true about the entity shown in the CT scan in the picture. Now this is very important topic. It's called the allergic fungal rhinosinusitis. This is seen in immunocompetent patient, not immunocompromised patient. Immunocompetent patient. It's mainly type 1 allergic reaction. Type 1 and type 3 they say, but mainly type 1 allergic reaction. And the typical findings are the peanut butter like nasal mucin means it is very thick mucus the nose, and it contains eosinophils, Charcot-Leyden crystals, and fungal hyphae. Look at the name, allergic fungal sinusitis. Fungus is also there, fungal hyphae, and allergic response is also there. Eosinophil and Charcot-Leyden crystal represent the allergic response to fungus. Then, the typical CT scan finding in this case. Patient got nasal polypi, allergic nasal mucin, the fungal nasal polypi in AFRS. On CT scan, they give double density or heterogeneous shadow. double density or heterogeneous shadows is very important. That's a very, very important question on CT scan. You see what in AFRS CT scan finding. What is AFRS full form? Allergic fungal rhinosinusitis. It gives double density or heterogeneous shadow. Please see on the screen, everybody. This is the fungus, white element. This is the allergic response. Can you see there are two different type of densities over there? The central part is whitish, which is fungus, and the blackish part around that is allergic response to the fungus. So the patient has got double density or heterogeneous shadows on CT scan. It's a classical question of the paper. Now treatment is FES followed by steroids. FES followed by steroids. What about antifungal? Now antifungal are only given. They are not the primary treatment. You don't give antifungal to every patient of AFRS. No. Antifungal are only given if there is invasion of surrounding areas. Antifungal are only given if there is invasion of surrounding areas, which is seen on MRI scan. Okay. So guys, the main treatment of allergic fungal sinusitis is FES followed by steroids. Do not give antifungal to everyone. Antifungal are only required if there is invasion of surrounding areas. Okay, fine. So, what is the answer? The answer is C. C. Antifungal therapy is not the primary treatment. The primary treatment will be you do the FES and you give the steroids. Antifungal are only given if there is involvement of surrounding areas, which is seen on MRI. So it is not the primary modality of treatment. So all are true for AFRS except is C. C is the answer. Okay. Now, a wide roomy cavity, nasal cavity with thick crust formation and bad odor. Roomy nasal cavity, crust is the main hallmark and bad odor from nose. This all indicate atrophic rhinitis, also called ozena. Ozena. Same MCQ. Same crust formation, same wide cavity, bad odor, plus hard external nose. There is crusting in the nose. There is roomy nasal cavity. Along with that, hard external nose is given. Then the answer will change to rhinoscloma. Are you getting my point? The patient is having all similar symptom of atrophic rhinitis. Along with that, if in the MCQ, the thing given is that there is hard external nose also, the answer will be rhinoscloma. So, the equation is atrophic rhinitis MCQ plus hard external nose is equal to rhinoscloma. Atrophic rhinitis MCQ plus hard external nose is equal to rhinoscloma. Okay, fine. Similarly, Quinsy MCQ, uvula push to other side, hot potato voice, trismus plus outer neck swelling close to angle of mandible is equal to parapharyngeal abscess. Once again, two questions to remember. Two MCQs can be confused. Atrophic rhinitis plus hard external nose is equal to rhinoscloma. Quinsy, same question of Quinsy. Uvula push to other side, tonsil push medially, hot potato voice, trismus. Along with that, outer neck swelling given to close to angle of mandible. Outer neck swelling here, close to angle of mandible is equal to parapharyngeal abscess. Just remember the two equations because these two MCQs are overlapping actually. So, rhinoscloma, woody nose, these are granulomas. And if you take a biopsy from here, then you will see what? Russell bodies and Mikulicz cell. They are feature of rhinoscloma. So, rhinoscloma, the two pathology findings are Russell bodies and Mikulicz cells. Anybody? What is the drug of choice? The drug of choice of rhinoscloma is tetracycline plus streptomycin. Drug of choice for rhinoscloma is tetracycline plus streptomycin. The second line drug is rifampicin. Second line drug for this case is rifampicin. Okay, fine. These are rhinoscloma, few basic things. Now, a patient of suspected sinusitis has undergone CT scan of the sinuses. The radiologist reports an anatomical variation of posterior corneal cell lying in close proximity to optic nerve. Optic nerve. What is the name of cell? Optic nerve. Very simple. O and N. O and N, O no D, O no D cell. O optic and nerve, O no D. Answer is O no D cell. Any cell close to optic nerve is called O no D. From O optic O, O no D cell. O no D cell, O no D cell. Optic O, N for nerve, O no D, optic nerve. Okay, O no D. Now, all are true for CSF rhinorrhea, beta. CSF leak from the nose. The most common cause nowadays is iatrogenic trauma, matlab FES. The commonest cause is some surgery like FES being done, and that's the commonest cause. And mostly in FES, which part injured? Cribriform plate. Cribriform plate is the commonest site of the leak. In such cases, during FES, you damage the cribriform plate, and that's the CSF leaking from there. In CSF leaking from the nose, what is the best confirmatory test? Beta 2 transferrin is the best confirmatory test to know it is CSF or nasal secretions. Number 3, HRCT skull base. HRCT skull base, high resolution CT of skull base is the best radiological investigation to find the site of leak. To confirm the site of, to confirm it is CSF or not, we do beta 2 transferrin estimation. But to find out the exact site of leak, the best radiological investigation is HRCT of the skull base. The treatment cannot be urgent surgery, beta. It is just a fracture there, beta. Some bone is broken. Give it a chance. It will heal automatically in lot of cases because of callus formation there. So treatment of CSF leak is not urgent surgical closure, beta. The treatment is conservative treatment. The treatment is conservative treatment for 7 to 10 days with bed rest and antibiotics. We do not do immediate surgical closure in this case. We always go for the conservative treatment for 7 to 10 days with bed rest and antibiotics. So B is not a correct statement. Answer is B. Immediate transnasal endoscopic closure should be done. No, not at all. We should do wait and watch conservative treatment because we are hoping lot of leaks will stop on their own. The answer to this question is B, B. It's not immediate, its treatment is conservative. Now, 37-year-old diabetic patient, ketoacidosis, there is a blackish nasal mass and necrosis of skin of the nose. What diagnosis is the mucormycosis? Mucormycosis. You know, mucormycosis can be seen in COVID-19 patient also, HIV positive patient also, and young diabetic patient also. Mucor is angio-invasive fungus. Angio-invasive means it grows into the blood vessels. That is why it reaches the orbit and brain very fast. Why it reaches orbit and brain very fast? Mucor is angio-invasive fungus, and that angio-invasion leads to spread of the fungus to the orbit and brain. And my dear friends, that is why it's a very life-threatening disease. You must be remembering the story of black fungus. Okay, the classical picture is blackish nasal mass and blackish discoloration around the eye also. Okay, black is the hallmark color. But do remember, as we discussed in the app also and class although, black color will not come immediately. Black color will always come after few days. In the initial color, the initial stage, the color of the skin of the cheek is reddish only. So redness over cheek, numbness over cheek, pain over cheek, some nasal discharge and loose upper teeth. Please remember, last Neet PG, they said no black color. They gave a very beautiful story and the upper teeth got loose in a diabetic patient and all that. Please see, upper teeth are part of maxilla. Where is the fungus? In the maxilla. Okay, so the black color will come in the late stages. Now, mucormycosis, we do radiological investigation of contrast MRI. Contrast MRI shows black turbinate sign. What is the black turbinate sign? Black turbinate sign is a feature of mucormycosis on radiology. So, the investigation for mucormycosis is contrast MRI and the name of sign is black turbinate sign. This is black turbinate. Can you see? This is the normal turbinate. This is normal turbinate and this is the black turbinate. So, black turbinate sign on contrast MRI is a feature of mucormycosis. Now, drug of choice. Number 1, debridement. Debridement. Why debridement? Dead. D for dead. D for debridement. Dead tissue need to be debrided. Number 2, drug of choice is liposomal amphotericin B. So first you do the debridement. because there is ischemia, necrosis, that's a black color, dead tissue, necrotic tissue to be debrided first of all. And number 2, liposomal amphotericin B. Okay, fine. That's a drug of choice. Now, all are true for Ringett's tumor of the nose except, first of all, it's also called inverted papilloma of nose. Inverted papilloma of nose, okay? My dear friends, Ringett's tumor is inverted papilloma nose. It arises from not upper part, it arises from lateral wall of nose. Lateral wall of nose. Okay, first answer is A, beta. Guys, Ringett's tumor does not arise from the septum, it arises from the lateral wall of nose. It grows inwards. Look at the name, beta. Inverted means it grows inwards. That's why inverted, therefore it's a locally invasive tumor, beta. It's more common in males. And the surgical treatment for this is called medial maxillectomy. Medial maxillectomy, beta. Please see. From where the word medial maxilla came, beta. Please see. This is inverted papilloma nose. Write down. It presents as smooth surfaced, pinkish red nasal mass. Smooth surface, pinkish red nasal mass. Pinkish red nasal mass. Can you see, beta? Smooth surface, pinkish red nasal mass. Guys, my dear friends, please highlight one thing. Rhinosporidiosis, which looks like similar, beta. You know, rhinosporidiosis is a strawberry or mulberry like nasal mass. That mass, there is a mass, that mass has got irregular studded surface. Irregular studded surface. Irregular studded surface. How to differentiate inverted papilloma nose from rhinosporidiosis? First of all, the history is different. In rhinosporidiosis, the history is of Tamil Nadu patient with the history of swimming or bathing in the ponds, because Rhinosporidium seabrai is aquatic protozoa. The question is totally different. Either resident of Tamil Nadu or patient with the history of bathing or swimming in the pond will be given with it. Rhinosporidiosis is an infection, and the mass of rhinosporidiosis has got similar appearance, but the surface of that is very classically irregular studded surface. However, the Ringett's tumor or inverted papilloma nose has got a similar kind of mass, but the surface of mass is smooth actually. Now, the site of origin is lateral wall of nose, beta. You see on the screen, everybody? This is the site of origin, beta. Now, lateral wall of nose, and the mass come out. Problem with this tumor is, this is locally invasive tumor, beta. Okay, if you remove the papilloma only, little bit part of that will be left, beta. So you must be removing the site of origin of this tumor also. What is the site of origin? Lateral wall of nose. What is site of origin? Lateral wall of nose. Look at me, beta. Lateral wall of nose is equal to medial wall of maxilla. Please see, lateral, this one, beta. Lateral wall of nose is medial wall of maxilla. So the name of surgery is medial maxillectomy. Name of surgery is medial maxillectomy. Okay, beta. From where this word came? Because the site of origin of tumor is lateral wall of nose, and lateral wall of nose should be removed. And I know from anatomy, lateral wall of nose is nothing but medial wall of maxilla. So what is the proper name of surgery done for inverted papilloma nose? The answer is medial maxillectomy. My dear friends, don't target mediocrity, beta. Okay? Please make sure that you are actually trying to gain as much knowledge as possible in the remaining days before the NEET PG March 2023, beta. We cannot do fully, beta. We cannot do fully. I 100% agree with that. Don't really, go for is, am, are, the written in the notes. Go with the main essence of those 3-4 pages. Try to, recall in your mind and finish the notes faster. Do the retrospective revision of notes. Come back to the notes and do, see the salient high yield point one more time. This kind of smart activity is better than just reading all the notes anti-grade like that, beta. Why not go anti-grade faster, use the MCQs, PYQs and do the retrospective retrograde revision of the same notes, particularly focusing on the high yield points. Guys, PYQs must be done. Everybody, PYQs must be done. Previous year questions, INSED question, at least, beta. 4 session, beta, at least. If not 4, 3 must be done, beta. 3 session of INICT, 3 session of NEET PG should be done by you. Those notes also, those notes of those topics also should be done. Not just the MCQs, those topics should be seen by you guys. Now, this is a patient of 62-year-old male with high blood pressure. Patient had, bleeding from nose. Management started, but the bleeding could not be controlled on anterior posterior packing. What is the next management? If you remember the notes for the class, endoscopic sphenopalatine artery ligation. What is the artery of epistaxis? Sphenopalatine artery. So in hypertensive bleed, if anterior posterior packing failed to control bleeding, then the answer is B beta, endoscopic ligation of sphenopalatine artery. What is ESPAL full form? Endoscopic sphenopalatine artery ligation. If anterior posterior nasal packing fail, then what is the next management? ESPAL beta. What is ESPAL? Endoscopic sphenopalatine artery ligation. Okay, fine. Now, 43-year-old patient suffering from acute frontal sinusitis. Look at me, beta. Frontal sinus mucosa is infected, sinusitis. But then he developed a painful red forehead swelling. Painful red forehead swelling, beta. Can you see, beta, this one? Painful red forehead swelling. This is actually subperiosteal frontal abscess, beta. Subperiosteal frontal abscess. This is called Pott's puffy tumor. Very, very, very famous question, beta. Don't confuse. Ringett's tumor is really a tumor. R for Ringett's, R for really. Ringett's tumor, really a tumor. This is other name of inverted papilloma of nose. But Pott's puffy tumor, star question, beta. Pott's puffy tumor is actually other name of subperiosteal frontal abscess, beta. Look at subperiosteal frontal abscess, beta. Okay. It presents as painful red forehead swelling. Now, let's go further. Which of the following is not true about ethmoid air cell, beta? Ethmoid air cell, beta. Look at screen, beta. Where is the ethmoid bone? Ethmoid bone is a single bone between the two orbits, beta. This is your ethmoid bone. Ethmoid bone is a single bone between two orbits, and these are the two halves of the ethmoid bone. These two halves contain few cells, and they are called ethmoid air cell, beta. In the front part of the bone, we have got anterior ethmoid air cell. In the back part of the bone, we have got the posterior ethmoid air cell. So, the ethmoid air cells are of two groups, anterior, posterior. Number wise, anterior is 2 to 8, posterior is 1 to 8 beta. Number wise, anterior is 2 to 8 and posterior is 1 to 8 beta. Okay. Now, first of all, and posterior ethmoid air cells are 1 to 8 in number, correct. Second one, look at me. Anterior cell, posterior cell. Anterior 2 to 8, posterior 1 to 8. What separates the anterior from posterior is a bony plate called the basal lamella or ground lamella. Okay, fine. Are you getting my point? The anterior cell and posterior cell are separated by a bony plate called ground lamella or basal lamella. Okay, now, I told you these two cells are minimum cell which anybody would have out of anterior ethmoid air cell beta. Now, anterior ethmoid air cell again are 2 to 8 in number. These two are constant cells. Every one will have them, constant cells. Okay. If they are constant, let us give name to them. The one cell is called bulla ethmodalis. Bulla ethmodalis. The other cell is called agar nasai. NASI, agar nasai. B for bulla, B for biggest. This is the largest anterior ethmoid air cell. And agar nasai is A for agar, A for anterior. It's anterior most anterior ethmoid air cell. Look at me, let's revise. Anterior ethmoid air cell are 2 to 8 in number. 2 are minimum constant cell which you have, I have. If they're constant, let's give name to them. The two anterior ethmoid air cells which are constant are labeled as number 1 bulla ethmodalis and number 2 agar nasai. B for bulla, B for biggest. So bulla ethmodalis is the largest anterior ethmoid air cell. Agar nasai, A for agar, A for anterior most. Agar nasai is the anterior most anterior ethmoid air cell beta. Okay, fine. Now, look at B is correct beta. C is wrong. Bulla ethmodalis is the anterior most ethmoid cell, wrong beta. Bulla is the largest, B for bulla, B for biggest. Anterior most is agar nasai beta. Anterior most is agar nasai beta. NASI. I hope you remember. C is not the correct, C is the answer. Bulla ethmodalis is not the anterior most. B for bulla, B for biggest cell beta. So bulla ethmodalis is the biggest or largest anterior ethmoid air cell, but agar nasai is the anterior most anterior ethmoid air cell. Heller cell is in the orbital floor beta. Heller cell is in the orbital floor. Now please see, bulla is okay, Bulla is the largest cell. Agar nasai is the anterior ethmoidal cell. Orbital cell, Heller cell is in the orbital floor. Onodi cell is close to optic nerve. Concha bullosa is inside middle turbinate. Once again, bulla ethmoidale is the biggest cell. Agar nasai is the anterior-most cell. If a cell is found in the orbital floor, it's called Haller cell. If a cell is found close to the optic nerve, Onodi cell. And if cell is found in the middle turbinate, it's called concha bullosa. And these are the two are the constant cell. These three are the variations. Variation means some people can have it. Okay, fine. Now, 16-year-old Pramila presents with pain over the cheek and lower part of the orbit. This is cheek pain. Pain over cheek is a feature of maxillary sinusitis. Patient also complains of nasal discharge. Examination reveals edema of the lower eyelids and purulent discharge in middle meatus. Please look at me, everybody. Pain over cheek is the main thing. The maxillary sinus drain into middle meatus. If you remember, middle meatus is the drainage of maxillary sinus. So this question asks, involvement of which sinus suspected? Answer is the maxillary sinus. What are the 2 points in favor? Number 1, the point is the patient pain over the cheek. Number 2, the discharge in the middle meatus. Because we know pain over cheek favors which diagnosis? The maxillary sinusitis. And the maxillary sinus drain into which meatus? Middle meatus. So both of these points support a diagnosis of maxillary sinusitis over there. Now, 7-year-old child while playing fell down. Trauma leading to nasal blockage on both sides. This is a classical question. It's not a fracture. There's no nasal deformity. After trauma, you get bilateral nasal blockage and swelling around the nose. Please see. It's a case of septal hematoma. Septal hematoma, can you see the blood collection? Blood collection over there. Septal hematoma. Treat it at the earliest possible. Put a needle to aspirate it out or do the incision drainage. Okay. Otherwise, what will happen? It will lead to septal abscess. And septal abscess will eat away the cartilage and that will lead to septal perforation. Okay, fine. Okay, you don't want all this. So, the treatment is aspiration of septal swelling or IND. What is IND? Incision and drainage. Okay, so a child or somebody playing, adult also playing, cycling, fell down. There is a bilateral nasal blockage. The clue is bilateral. The clue is bilateral nasal blockage. Bilateral nasal blockage. Okay, fine. Now, and this swelling around. Why it's not a fracture, Because fracture would have what? Nasal deformity. In the fracture, there will be nasal deformity. It's not a fracture. There is no nasal deformity. It's a case of traumatic septal hematoma and treatment is aspiration or incision and drainage. Otherwise, it will convert to septal abscess and that will lead to septal perforation. Which disease causes perforation of bony part of septum? Bony part of septum is tertiary syphilis. Tertiary syphilis. Tertiary syphilis lead to perforation of bony part of septum. Now, one disease which is important for you guys is Wegener's granulomatosis. One autoimmune disease which can be asked in ENT is Wegener's granulomatosis. Okay. Now, the most common presentation of vaginal granulomatosis in ENT is sinusitis. First of all, most common ENT manifestation of vaginal granulomatosis is sinusitis. Now, there can be epistaxis, there can be septal perforation. In septal perforation, both bony and cartilaginous part can be involved, not just bony or not just cartilaginous, septal perforation. And there can be additional symptom like hemoptysis. Hemoptysis, okay? Because there is a multi-system involvement in Wegener's autoimmune diseases. So, there were ENT symptom like sinusitis, epistaxis, septal perforation. Along with that, hemoptysis is also given. Think of vaginal granulomatosis. This is a possible question. This is a possible question. Why hemoptysis? Because there will be other system involvement in Wegener's also. Next one. Identify the findings shown in the CT scan. Because let's evaluate the CT. Where we are. This is your orbit and orbit. This is maxillary sinus. This is also maxillary sinus. Okay, fine. Now, this is your ethmoid bone. This is ethmoid bone. Ethmoid bone is a single bone between the two orbits. Beta. Ethmoid bone is full of air cells. Beta. Can you see it full of air cells? There are many air cells there. Okay. Now please do remember, inferior turbinate or inferior concha is independent bone, but middle concha are part of ethmoid bone. Beta. They are part of which bone? They are part of ethmoid bone. This is the middle concha. Beta. Middle concha. Now within the middle concha, you see a cell. That cell, this cell is called the middle concha bullosa. Beta. Concha bullosa. Once again, please see. This is the middle turbinate coming down. Okay. This is the concha bullosa. Now, try to recall, inferior turbinate or inferior concha is an independent bone, this one. But middle turbinate is a part of which bone? E. What is E? Ethmoid bone. In that you see a cell, and that cell is called concha bullosa, because what is definition of concha bullosa? Concha bullosa is pneumatization of middle turbinate. This is concha bullosa. Concha bullosa is if ethmoid air cell grows into middle turbinate, that was concha bullosa, and this is a typical look of the concha bullosa. The answer is C, concha bullosa. Okay, fine. Now, all are true about malignancy of sinuses except, first of all, most common sinus to develop malignancy is maxillary followed by ethmoid. Maxillary followed by ethmoid. Now, second thing to remember is the risk factor are very unique. One risk factor is nickel, and nickel exposure lead to squamous cell carcinoma. And wood dust. Carpenters, wood dust exposure lead to adenocarcinoma of ethmoid. Adenocarcinoma of ethmoid. Okay. Therefore, it is also called wood workers carcinoma. I repeat, there are two risk factors for the malignancy of sinuses. Very unique, not cigarette, alcohol. It's the occupational exposure to nickel and occupational exposure to the wood dust. Now, nickel exposed patient develops squamous cell carcinoma, and very surprisingly, the wood dust exposed patients, the carpenters particularly, they develop adenocarcinoma of ethmoid, and that is why adenocarcinoma of ethmoid is also called as woodworkers carcinoma. For this tumor of maxillary sinus, we use a line which is called Ongren line. Ongren line is used for cancer of which sinus? Maxillary sinus. And this is this for surgery? No. This is for prognosis of this cancer. Prognosis, beta. This line, Ongren line, it's from medial canthus to angle of mandible. Ongren, O-H-N-G-R-E-N. Ongren's line is from medial canthus to angle of mandible. The significance is any tumor above this line will enter the eye very fast. Beta. Any tumor, any cancer above this line will have poor prognosis. Beta. Poor prognosis due to early orbital involvement. Once again, Ongren line is used for assessment of prognosis in a patient of carcinoma of the maxillary sinus, and this line is from medial canthus to the angle of mandible. Any cancer above this line will have poor prognosis due to early orbital involvement. The name of surgery for carcinoma maxillary sinus is called total maxillectomy, and for total maxillectomy we use an incision called Weber-Ferguson incision. The name of surgery is total maxillectomy. For total maxillectomy, we use an approach or incision called Weber-Ferguson incision. How to identify it? It is upper lip splitting incision. Upper lip splitting incision. There is only one incision which is cutting the upper lip, is the Weber-Ferguson incision. Okay. So this incision is used for total maxillectomy. How to identify it? This incision will be passing through the upper lip area. Okay. So what is the answer to this question? Please see. All are true for the sinuses malignancy except Weber-Ferguson incision used for total maxillectomy. Correct. Nickel exposure leads to squamous cell carcinoma. Correct. The squamous cell carcinoma sinuses are more common in furniture industry workers. Wrong. It's adenocarcinoma. I told you. Furniture industry worker means carpenter. They do not get squamous cell carcinoma. They get adenocarcinoma of ethmoid. Okay, once again, the nickel exposure develops squamous cell carcinoma, but wood dust exposed people develop adenocarcinoma of ethmoid, which is also called woodworkers carcinoma. D. tumors of infrastructure beta, below the Ongren line, will have better prognosis beta. So guys, let's start the next question now. 27-year-old man present with the complaint of chronic nasal congestion. About 2 months earlier, he had an upper respiratory infection with rhinorrhea and nasal congestion. Since then, he continues to have severe nasal congestion, for which he uses oxymetazoline twice daily for last so many months actually. Okay. Now he has got neither erythematous with swollen turbinate, no purulent discharge. Now this is a case of rhinitis medicamentosa, which is due to prolonged use of topical decongestant drops like oxymetazoline or xylometazoline. And this prolonged use lead to rebound congestion. Rebound congestion means the moment the effect of the drug finishes, there is a reflex vasodilatation in the turbinate, inferior turbinate gets again swollen because there is a reflex vasodilatation actually, and that increases the size of the inferior turbinate, becomes very boggy, very enlarged, and that makes the patient find difficult to breathe. So in that case, if you put the nasal drop again, it gets decongested better. Okay, fine. Now, but this cannot go on and on and on. What is the treatment of rhinitis medicamentosa is the question. What is the appropriate treatment for this condition? The answer is discontinue these oxymetazoline drops and start steroid nasal spray. That's the answer. Start steroid nasal spray. Because steroid spray, if you put it, they will lead to shrinkage of the turbinate. And when turbinate gets shrunken, you will have better airway to breathe over there. Okay. The answer is D beta over there. Okay. It's a case of rhinitis medicamentosa, and the treatment is stop the drops and start steroid nasal spray. Now, 2-year-old child present to emergency with fever, respiratory distress, drooling of saliva, and mother told that he refusing feed since yesterday, means dysphagia also. The X-ray is given over there. Please see this X-ray. This is actually typical X-ray with the widening of prevertebral shadow, and this is a case of acute retropharyngeal abscess. Acute retropharyngeal abscess is a pediatric airway emergency. It is due to suppurative infection of retropharyngeal lymph nodes. So there is intraorally on the posterior pharyngeal wall, there is a big bulge of the pus over there. That makes the breathing difficult, stridor is there, difficulty in swallowing, hot potato voice. Now, acute retropharyngeal abscess is a serious pediatric airway emergency. The X-ray shows widening of prevertebral shadow. What the technical word? Widening of prevertebral shadow with normal cervical vertebrae. With normal cervical vertebrae. Okay, fine. The treatment of this will be first airway management. Airway management. All of the following are part of laryngopharynx except laryngopharynx is also called hypopharynx. Laryngopharynx is on the side of larynx and behind the larynx. Laryngopharynx also called hypopharynx. Here it is. It is on the side of the larynx and behind the larynx also. Okay. Now, please see, this is your larynx. On the both sides of the larynx is PS, piriform sinus right and left. What is PCA? Post-cricoid area. And what is PPW? Posterior pharyngeal wall. So, laryngopharynx or hypopharynx has got three parts. Number one, piriform sinus right and left. Number two, post-cricoid area. And number three, posterior pharyngeal wall. Okay, now look at real. This is your, of course, larynx or supraglottis. This is your laryngopharynx. Piriform sinus, post-cricoid area, and this mucosa is called posterior pharyngeal wall. Okay, so if they ever put an arrow on the side of the larynx like this, what is this arrow indicating? Piriform sinus. Okay, so laryngopharynx or hypopharynx got three parts: two piriform sinuses, post-cricoid area, posterior pharyngeal wall, and the visual question in front of you. If they ever show you an arrow on the side of the larynx, it is piriform sinus. Mind you, piriform sinus is also called piriform fossa. Little bit MCQ word can be gone this side, that way. Don't get confused. Don't change the answer. Piriform sinus, some will call it piriform fossa. Don't worry. The examiner can play with the word little bit, but don't change the answer for that. Little bit change the word. Let's go with the answer. All are following a part of laryngopharynx except, please see. See, postcricoid area, yes. Piriform sinus, yes. Vallicula, no. Posterior pharyngeal wall, yes. Vallicula is a part of oropharynx. Vallicula is a part of oropharynx. Vallicula is the space between base of tongue and epiglottis. There is a valley. When the base of tongue is ending and epiglottis is starting, that valley is called a vallicula. Vallicula is a part of oropharynx, not hypopharynx. All are true about Ludwig angina, beta. Ludwig angina is infection of floor of mouth over here. Floor of mouth, beta. The floor of mouth also called submandibular space. Okay, submandibular space, beta. Now what happens is, this is your one of the mandible, beta. So guys, this is your mandible, and on the mandible, this is molar, premolar. One of the molar or premolar got infected, dental caries, and that got this side. So Ludwig angina story will always start with dental infection causing chin swelling and trismus. So what are two symptoms over here? One is chin swelling and other is trismus, beta. Sometimes the swelling is so much, there is difficulty in breathing also, beta. Plus minus respiratory difficulty. Okay. So main thing is, after dental infection, somebody develops chin swelling and trismus, plus minus difficulty in breathing also, beta. What are the bacteria responsible? Guys, oral, beta, oral, not Staph aureus, beta, oral, streptococci. The bacteria responsible are streptococci and anaerobes, beta. Oral, na? Mixed bacteria. Microbiology question also. What are the bacteria responsible for Ludwig angina? Streptococci anaerobes means mixed bacteria. Mixed bacteria, beta. Okay, fine. Now, fine. Please see. What is the answer, beta? All are true about Ludwig angina except trismus is a feature, yes. Tracheostomy may be required, yes. Why? Plus minus respiratory distress, beta. I told you, the patient might be having difficulty in breathing due to over swelling actually over there. You can ask me, Rajiv, why can't you intubate? There is trismus. What is trismus? Difficulty in mouth opening. If mouth cannot be open, how can you intubate easily? Okay, fine. So, tracheostomy may be required. It's a submandibular space infection. Yes, it's an infection of floor of mouth. What is floor of mouth? Technical name, submandibular space. Floor of mouth, this one, submandibular space. What is the bacteria culprit? It's mixed bacteriology. It's not Staph aureus. D is incorrect. It is streptococci and anaerobes. The answer is D. D. Okay. Once again, after dental infection, somebody developed chin swelling and trismus. With and without respiratory distress is a case of Ludwig angina. Now, all are true for nasopharyngeal carcinoma, except, my dear friend, if you remember, the nasopharyngeal carcinoma, the most common presentation is metastatic cervical lymphadenopathy. The most common clinical presentation of nasopharyngeal carcinoma is metastatic cervical lymphadenopathy. A very commonly done mistake in the paper. People write conductive hearing loss or something like that. Conductive hearing loss is seen, but okay. But it's not the commonest presentation. How to remember? NPC, nasopharyngeal carcinoma. The first letter is N. The most symptom also come in N. What is N? Neck. Something in the neck, beta. The earliest commonest presentation or the commonest presentation of NPC is the neck swelling or metastatic cervical lymphadenopathy. And I hope you remember, nasopharyngeal carcinoma has a triad called Trotter's triad. Nasopharyngeal carcinoma due to cranial nerve involvement, it lead to triad called Trotter's triad. Okay, Trotter's triad, the mnemonic is NPC. 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 What is N? Neuralgia in temporoparietal area due to fifth nerve involvement. P. Palatal palsy due to 10th nerve involvement. And C. Conductive hearing loss due to glue ear. Glue ear. All are unilateral. Unilateral. So once again, what is the name of triad for nasopharyngeal carcinoma? Trotter's triad. The mnemonic is also NPC. What is N? Neuralgia in temporoparietal area due to fifth nerve involvement. P. Palatal palsy due to 10th nerve involvement. C. Conductive hearing loss due to glue ear. All are unilateral. Which virus causes nasopharyngeal carcinoma? Epstein-Barr virus. What is the age of the patient? Adult patient. Adult patient, 50 to 60 years, mostly in the question. Okay, fine. The treatment of choice of nasopharyngeal carcinoma. Guys, NPC is a radio-sensitive tumor, but when combined with chemotherapy, radiotherapy effect is enhanced. So, best answer will be chemo radiation. My dear friends, my main thing is radiation, beta. Chemo is a supportive thing along with that, okay? Chemo radiation. But if chemo radiation is not the choice, then you mark radiotherapy. For God's sake, do not mark chemotherapy over there. Do not mark chemotherapy. Chemo radiation means main thing is radiotherapy. Along with that, you give chemotherapy. But if chemo radiation is not in the choice, then you mark radiotherapy. Beta. Okay, fine. Now, let's see the question. Beta. All are true for NPC except, please see, palatal palsy, yes. Temporoparietal neuralgia, yes. SNHL, wrong. Answer is D. It's not SNHL, it's conductive hearing loss. It's conductive hearing loss. Okay, fine. Next question. The investigator's choice for a 12-year-old male child presenting with polypidal mass in nose which bleeds on touch. My dear friend, this is a typical case of angiofibroma. Angiofibroma. Please, please, please. A young boy with nasal mass and epistaxis angiofibroma. A female patient with something pulsating or bleeding in the ear is glomus jugulare question. My dear friends, there are two vascular tumor of ENT. One in male, one in female. A young boy with a nasal mass and epistaxis is angiofibroma. A lady with something pulsating or bleeding in the ear is glomus jugulare question. Okay? Now, this is the case of angiofibroma. The best would be CCT and angiography. CT would not be good, but a contrast CT for vascular thing, and of course angiography also. If you remember, the CCT would show which sign? Hallman-Miller sign. This is the Hallman-Miller sign. This is the Hallman-Miller sign. Okay, what is this? This is the maxilla. The tumor is pushing the maxilla forward. It is the anterior bowing or posterior wall of maxilla. Bowing, B-O-W-I-N-G. It is anterior bowing or posterior wall of maxilla. Anterior bowing or posterior wall of maxilla. Look at the red arrow. The red arrow represents a tumor. The tumor has pushed the posterior wall of maxilla forward. This anterior bowing of the posterior wall of maxilla by the tumor is called Hallman-Miller sign or antral sign. Why you do the angiography? You do angiography to find out the most dominant source of blood supply for the angiofibroma tumor before surgery. So angiography shows that the most dominant source of blood supply for the tumor is maxillary artery. So angiography will tell you before surgery, this artery is the major blood supply of the angiofibroma. What you do before surgery? Pre-operative embolization of this artery. Ask the radiologist to do pre-operative embolization of this artery. This will reduce the blood loss during surgery. These things you are doing 1 or 2 days before the surgery. Reduce blood loss during surgery. So before 1 or 2 days before surgery, do the angiography to find out the most dominant source of blood supply for angiofibroma, and generally the report says maxillary artery. So you request for pre-operative embolization of the artery, and that reduces blood loss during surgery. Okay? Laser palatoplasty. This surgery is done for which problem? Snoring. Some people have snoring like this, beta. Why? The palate is weak, the palate is actually fluttering like that. And any mucosa when it vibrates produces sound. You want to make the palate strengthen, you shoot the laser beam on the palate in multiple places. Laser induces fibrosis, means tight. If the laser induces fibrosis, palate becomes tight, the tight palate will not move that much. So laser palatoplasty is used for management which problem? Snoring. And there is another surgery called laser uvulopalato-pharyngoplasty. I think the longest word of ENT. UP3 surgery, beta. UP3 surgery. Uvulopalato-pharyngoplasty. This surgery is done for obstructive sleep apnea. Laser uvulopalato-pharyngoplasty. This surgery is done for obstructive sleep apnea. You know, some people are very obese. They've got a lot of extra tissue in the oropharynx. You remove that extra tissue, and that surgery is called laser uvulopalato-pharyngoplasty. So let's revise. Laser palatoplasty is for snoring, but uvulopalato-pharyngoplasty is for obstructive sleep apnea. Now, clinical scenario-based question. A 6-year-old child operated for adenotonsillectomy under general anesthesia. In the evening, developed neck spasm. MRI shows atlantoaxial subluxation. Look at me. The position of the patient during adenotonsillectomy is called a Rose position. And if you remember, Rose position is neck extension. Neck extension. But over neck extension can lead to C1, C2 or atlantoaxial subluxation. Okay? And the possible diagnosis in this case will be Grissel syndrome. Okay? Grissel syndrome. You know, remember? The position of the patient during surgery is called Rose position. It is actually neck extension, but over neck extension can lead to atlantoaxial subluxation. And that is called Grissel syndrome. Grissel syndrome. Now, all are true about juvenile angiofibroma except frog face deformity. Yes, angiofibroma can extend to orbit, and that orbital extension will lead to proptosis. And that proptosis is called frog face deformity. This is frog face deformity. It's typical of angiofibroma. Frog face deformity is typical of angiofibroma. Adenoid hypertrophy, the face is adenoid face, beta. Mouth open and all that different. Adenoid face is adenoid hypertrophy. Frog face deformity is typical of angiofibroma. Mind you, angiofibroma is the most common benign tumor of nasopharynx, beta. Angiofibroma is the most common benign tumor of nasopharynx. The site of origin is the sphenopalatine foramen, particularly superior margin of that. Okay, the site of origin of this tumor is superior margin of sphenopalatine foramen. As you know, angiofibroma typically involves the adolescent boys, generally 12 to 16 year of males. So angiofibroma is a tumor of adolescent boys, 12 to 16 years, and it's a highly vascular tumor. Since it is occurring in and around puberty, it means it has got some dependence on androgen. Okay, so if you give flutamide, which is anti-androgen, that can induce shrinkage of the tumor. Look at me. This tumor is a highly vascular tumor, mostly seen in adolescent boys around 12 to 16 years, means in and around the puberty. This is a hormone-sensitive tumor. Therefore, if you give flutamide, which is anti-androgen, or estrogen before surgery, okay, pre-operative flutamide or pre-operative estrogen will shrink the tumor before surgery, because this is an androgen-dependent tumor. Now, the tumor can go from nasopharynx to nose, to cheek, to orbit and brain. The early stages will only be into the nose, When the tumor has only gone from nasopharynx to nose, is a limited angiofibroma. Nowadays, the best surgical approach for that is endoscopic approach. So, B is the wrong choice, You see, B is the wrong choice. Weber-Ferguson transmaxillary approach is ideal for angiofibroma limited to nose and nasopharynx? No. For angiofibroma limited to nose and nasopharynx, the best approach will be endoscopic approach. This is just the beginning of the tumor. The tumor has come from nasopharynx to nose, so we can handle it endoscopically. Okay, fine. For the tumor going to cheek, you need Weber-Ferguson approach. Okay, fine. So the answer to this question is B, B. So the best approach for limited angiofibroma to nose nasopharynx will be endoscopic approach. Endoscopic approach. So guys, these were the various questions which we posted to all of you in 2 elite tests, which comprises of one section of the ear, other section of the nose, larynx and pharynx, and we discussed the many key points of ENT for the NEET PG examination, also for the FMG examination. A couple of points are there over there. So guys, make sure that you revise this whole video, close to examination also one more time. It would be just a rapid run through of ENT for the various important points like cochlear implant, the bone anchored hearing aid, the brainstem implant, the superior canal Dyson syndrome, audiometry finding, tuning fork questions, and similarly, laryngeal cancer, the lot of points around the atrophy rhinitis, CSF rhinorrhea, they're covered in this video. The idea of doing such videos by DocTutorials is to give you an insight into the questions which are being asked nowadays, with a trending question and the relevant concepts behind those questions. So the last thing I would say to all of you guys, result is not in your hands, for sure. And if you keep worrying about the result, if you keep really thinking about what if this goes wrong, believe me, we are wasting our time. You're coming in the way of the destiny. You're coming in that domain which is not yours. Your domain is hard work. Let us do smart hard work. Let us do consistent hard work. Let us live every day so passionately, thinking that if these few days, maybe 3 months left over there, are going to decide my quality of life for next 40, 50 years, then why should I need a motivation for that? Then I should become my own motivator. I should talk to myself and I should start delivering every day effectively. Please, please, please make sure that you're studying more than 12 hours every day. Every day do some question. Keep 2.5 hour unit for MCQs only. MCQs means faster retrograde review of your notes of the high yield points actually. My best wishes to all of you. Will be staying connected further. Thank you very much.